sound. We can start.
So, good morning, good afternoon, good evening, depending on where you are over the globe. We met yesterday briefly. My name is Ali Youssef. I'm a consultant of Obstetrics and Gynaecology and Fetal Medicine in the University of Bologna in Italy. And I'm the member of the ISWOG Board of Trustees and the social media editor of the Journal of Ultrasound in Obstetrics and Gynaecology. Well, in this lecture, I'll be talking about an extremely relevant, clinically relevant and important topic, which makes part of the daily practice of any gynecologist or operator or examiner performing ultrasound in obstetrics, which is the mid-trimester scan. And we will be going in a systematic way according to the guidelines of the International Society of Ultrasound in Obstetrics and Gynaecology, the ISWOG. So I have written in the chat two resources. The first one is the link for the whole ISWOG guidelines, which are free access. So you do not need to be a member of ISWOG or to insert your contact, your access information to enter and access them. They're free access for everyone. And in the second link, I put a specific link of the mid-trimester guidelines, which we'll be talking about today. I'll try to be as exhaustive as I can with the limit of the time, but you are invited to visit frequently the ISWOG website, and not only for the guidelines and for the documents, but also for a lot of resources like the visual encyclopedia, like a lot of lectures from the past congresses and courses of ISWOG, which are all extremely relevant and useful from my point of view. So before starting, although this is not a technical part, but it's definitely an important part in the communication, because the communication of the examination is extremely important for both for the doctors and for the couple. Women should know that although the ultrasound and the mid-trimester scan is has a high accuracy for many malformations, they have to know that some malformations may be and will be missed in some women in the mid-trimester for many reasons. So, and they should be counseled about the benefits and limitation of the routine mid-trimester scan. Usually from a practical point of view, what we say in 30 seconds or 1 minute is that the exam at the end of exam, in the beginning we say that we'll be doing an examination which is quite accurate, but it does not exclude 100% of malformations. At the end, once everything we do not see any malformation, we do a summary of examples of what can be missed. So we say that everything has went fine, but there are some malformations that we cannot exclude with certainty in the mid-trimester, which are maybe mainly 3 categories: the very small malformations, like very small VSDs, which may be below the under the threshold of the accuracy of the ultrasound, some malformation that exists in some places in which ultrasound cannot reach accurately, like isolated posterior palate, for example, malformation. And the third big category of malformation that we cannot exclude in the mid-trimester scan are developmental malformations, like, for example, GIP obstructions, coarctation, and some evolutionary developmental malformation at the level of the central nervous system. Just to give some examples, which we'll be discussing in detail in the CNS lecture. And these are the main aims, the big aims of the mid-trimester scan. So we have to check for fetal activity, fetal cardiac activity, the fetal numbers, and chorionicity in case of multiple pregnancy. This sometimes cannot be very easy in the second trimester, and the third trimester is the right moment to check for chorionicity and amnionicity. And on Saturday, I'll be having a lecture on the multiple pregnancy. To check the fetal age/size. So if the pregnancy has already been dated, okay, and in the first trimester, we should only check for the fetal growth. If the pregnancy, the first time that we see the patient in the mid-trimester, this should not happen ideally, but we can use ultrasound to date the pregnancy or redate it. The placental appearance and location, and I believe that Dr. Fox has yesterday talked about the placenta, the amniotic fluid assessment, and finally the main topic of today, which is the basic fetal anatomy. So the ISWA guidelines, its main aim is not to give the whole spectrum of what can be seen in the fetus, but what the ISWA believe is the minimum requirements, okay, for a basic fetal anatomy scan. So you can go beyond these guidelines, but if you do not see structures as recommended in the basic fetal anatomy scan, this means that you have not fulfilled the minimum requirements, and you should refer the patient for a higher level in order to be able to fulfill the requirements of the examination. So when should the mid-trimester ultrasound be performed? Well, there is a range. Usually the recommendation is between 18 and 22 weeks, okay? This is the ideal age to check for the fetal anatomy. And one of the reasons of the limitation of to 22 weeks is you have to consider it depending on where you are practicing. Okay, because just to give you an example of what should be considered. So in Italy, for example, termination of pregnancy cannot be performed for any reason beyond 22 weeks plus 3 days. Okay, so actually there is some flexibility in the days, but not beyond, never beyond 23 weeks. So it would be too risky to do any mid-trimester scan in our context beyond 23 weeks. Although from a technical point of view, 24 weeks or 23 weeks would be appropriate, okay? But that in our context, that would be extremely inappropriate to check for the fetal anatomy for this age, okay? 18 weeks for some structures can be too early, okay? But you can already check for the mid-trimester scan anatomy from 18 weeks. So the range is from 18 to 22 weeks, and you should adapt it considering the conditions in which you're practicing. What is extremely necessary and indispensable is to give the patient a report detailing what has been seen, and if it's normal or if it's abnormal. If you're working in a context in which you have your software, or if you have a pre-filled module that you can use, this can be used. Otherwise, integrated inside the ISWA guideline, there is one paper in which you can print, and you can just fill it and give it to the patient. This has many advantages. The first one is that this reminds you if you forgot to see any structure. Okay. Secondly, this documents that you have performed the examination according to international guidelines, and that you have been keen on obtaining the necessary required scans. The fetal biometry has been, I believe that it has been discussed yesterday. we'll just go rapidly since you have already seen it, but you should use a standardized measurement. The gestation age, if it's already been determined in the first trimester, the second trimester scan should not be used as a dating method, but only for a measurement of the fetal growth, depending on the determined already fetal gestation age. This is extremely important because in some practitioners in some places do change the expected date of delivery every time they see the patient. Okay, and this is extremely confusing and it's conceptually wrong. Okay? So the first trimester is the right time to date the pregnancy. Once it has been done appropriately, okay, any further ultrasound scan should be used only to check for the fetal growth in comparison described in percentiles according to the actual gestation age. Otherwise, if you see the patient for the first time in the second trimester, ideally you should use a combination of the biparietal diameter, head circumference, and femur length to plus or minus the abdominal circumference. So it's ideally, you can use the biparietal, you can use the head circumference, or you can use a combination. There is no evidence which is superior, but we usually use a combination of the biparietal, head circumference, abdominal circumference, and the fetal femur length. Okay. So the biparietal diameter, which is anatomically an important view. So it's a cross-sectional view of the fetal head. Ideally, the angle of insonation should be perpendicular to the midline. So the midline should be horizontal. Okay. You should see a symmetrical symmetry in the hemisphere. So the midline should be ideally in exactly midway between the two skull bones. Okay. You should see the cavum septipellucidum, and this will see it in details when we'll talk about the fetal brain anatomy. And you should not see the cerebellum. So whether to measure outer inner or outer outer, okay, so from the outer plate of the proximal skull bone to the inner or outer side of the distal skull bone, there is no ideal answer to that, but usually this depends on which reference values you are using. The vast majority of the reference values used worldwide use the outer inner technique for the measurement of the fetal biparietal diameter. The head circumference can be measured on the on the transventricular view. So this is the cavum septum pellucidi, the anterior horns of lateral ventricle. This is the posterior horn of the lateral ventricle with the choroid plexus. So this is the transventricular view of the fetal brain, whereas this is a slightly different view in which we see the thalami. Okay, so this is the transthalamic view. To measure the head circumference, you can use whether the transventricular or the transthalamic, whereas this is a lower view in which you see this dumbbell-shaped structure posteriorly, and this is the cerebellum, and this is the transcerebellar view. And the transcerebellar view is an inappropriate view to measure the head circumference, so you should not be using it for that aim. Another important parameter for the fetal biometry is the abdominal circumference. So you should get a transverse section of the fetal abdomen. You should see the umbilical vein at the level of the portal sinus, so only the middle third of the umbilical vein. You should see the stomach, and you should not see the fetal kidneys. Okay? And if you take the appropriate view, you should see this is the portal sinus of the umbilical vein. You should not see it arriving to reaching the abdominal wall, because if you get the lower image, if you see it going to the abdominal wall, this means that you are getting an oblique view of the abdomen. Whereas if you get an ideal transverse view, you should cut only inside an intra-abdominal part of the umbilical vein. Okay. So this is the view that we have to see. So this is the stomach. Okay, the rib is the aorta, posterior and to the left, the inferior vena cava, anterior and to the right, and this is the umbilical vein. So that would be the ideal view to get the abdominal circumference. The femur length, you should measure only the diaphysis, so you should not be measuring the trochanter or the spikes outside the femur, so only the diaphysis. So let's go into the anatomy. So we study the fetal head, face, neck, chest and heart, abdomen, skeletal system, placenta, umbilical cord, and genitalia. So the skull, we should comment on the size, shape, integrity, and density. So we have to measure the skull. We have to see if it's an oval shape or there is any irregularities in the fetal skull. Okay, we should exclude that there are any defects in the fetal skull bone, and we should see it as a hyperechogenic plate and not an iso or anechoic plate. What about the fetal face? So the fetal face, what is obligatory that you have to see in the fetal face is the upper lip and the two orbits. Although the midline profile is recommended, but it's not obligatory in the ISWO guidelines, and the nose and nostrils are recommended, but are not obligatory in the ISWO guideline. And this is how we should see the indispensable view of the fetal face. So these are the orbits with the lens, okay? And normally the transverse diameter of each orbit, okay, should be equal to the interorbital space. So this should be distributed as a almost equal distances. You do not have routinely to measure this, but this is a more of a subjective assessment. You measure it only if you have a suspicion, and then take the coronal view of the fetal face, seeing the upper lip, which is indispensable. If you get the proper view, you can see the nose, nostrils, lower lip, and chin. And from this view, the transorbital view, if you have the two orbits on the same level, okay, exactly horizontally, you rotate the probe the transducer by 90 degrees, you will get the midline of the fetal face. Okay, so this is the front, the nasal bone, the nose, the upper, the palate, the upper lip, lower lip, and chin with the mandible. And this is how to obtain the lip view. Here we can also see the nose, nostrils, lower lip, and chin. So it's in a coronal view, and then you go out and in till you get the ideal view, which would be this one. Yeah. So this is the ideal view: nose, nostrils, upper lip, lower lip, and chin. This is the midline view. Okay, and then here in that case, we can see also the midline structure of the fetal brain, which we'll be talking about in the next lecture. Okay, so you can see the nasal bone, the nose, upper lip, lower lip, and mandible. Okay, you do not, it's not obligatory to measure routinely any measurements, to take any measurements in the fetal face. Okay, so you do not have to measure routinely the nasal bone. You don't have to measure any specific measurements in the fetal face. Only if you have any suspicions, this can be useful. Okay? An additional extremely useful but not obligatory view is the transverse scanning of the fetal face. Okay? So if you you move down, you take the fetal orbis view, and then you move down. Okay, you can see the transverse view of the palate, lip, tongue, and mandible. So here you can see the orbis. You go down, you see the palate, okay, and the upper lip. You go further down, this is the tongue and the pharynx. And then you go further down and you see the fetal, the mandible. Okay. What about the thorax? You should check in the sagittal view, the shape of the thorax should be regular with a smooth transition between the thorax and the abdomen. Okay. On the axial view, you should see the ribs with a normal curvature with no fractures or deformities. And then in the axial view, you should see both lungs view homogeneous without any evidence of a mediastinal shift or masses of the chest. And you should see the fetal diaphragm. Okay? So in a simple way, if you take the sagittal view and then move from left to right, here you can see the smooth transition between the thorax and the abdomen. You can see the diaphragm, you can see the thorax, the heart in the thorax, and you can see the stomach in the abdomen. Okay? And then you move from left to right, and you see the integrity of the diaphragm from left to right. So you can see the diaphragm on the right side, you can see the lung, and down you can see the liver. Moving down to the abdomen, you should check for the abdominal situs. So the stomach should be on the left, the aorta back and to the left, and the inferior vena cava forward anteriorly and to the right, with the umbilical vein that is rotating towards the right side of the fetus. On the left side, you should see the stomach, and on the right side, you should see the fetal gallbladder. And the bowel should be contained inside the abdomen, so you should not see any defect in the abdominal wall, and you should not see any collection, so ascites or cysts inside the abdomen. Whether to check for the cord vessels, the number of the cord vessel is not obligatory, but you have to know that the ISO guidelines do not need to use the Doppler. Okay, so if you have a machine without Doppler, okay, you can do the whole mitral mass scan, and so the easiest way to check for the vessels of the cord is to check them on the level of the fetal urinary bladder by putting the Doppler. Okay, although if you do not have the Doppler, you can use actually the 2D ultrasound, the grayscale, to check for the number of the vessel, and we'll see it later. Okay. So here you can see the insertion of the umbilical cord in the abdominal wall, so you do not see any defects, not central in the cord like the omphalocele, and you cannot see any intestine going out in the liquid, the amniotic fluid, like in case of gastroschisis. And you can see here the gallbladder in on the right side of the fetus. Sometimes in the beginning of your scanning, you're not sure if this is the gallbladder or the umbilical vein. Well, it's the gallbladder is more lateral in comparison with the umbilical vein, and you have some doubt. And if you have Doppler in the machine, just put the Doppler and you'll see if it's umbilical vein, you'll see some blood flow. And in case of the gallbladder, you'll see just a cystic structure without any blood flow. And this is how you can see a single umbilical artery in the 2D ultrasound. So in case of the 3 vessel cord, you see a large vessel and 2 other small circular vessels, so the umbilical vein and the 2 umbilical arteries. Whereas in the single umbilical artery, so in the 2 vessel cord, you can see only 2 structures, one larger, which is the vein, and one smaller and circular, which is the artery. What about the kidneys and the gallbladder? Well, ideally, you should take the axial view of the fetal abdomen at the level of the umbilicus. So here you can see on the axial view the spine. So this is the body of the vertebral bodies, the transverse processes. And then here you can see the kidneys, and you can distinguish the kidneys mainly by seeing the renal pelvis, which is very important, both to check for the presence of the kidneys and to exclude any dilatations in the renal pelvis. Okay, the most used cutoff to define the normality of the anteroposterior diameter of the renal pelvis is 4 millimeters in the mid trimester and 7 millimeters in the second trimesters. In the second trimester, although some use 7 millimeters in the second trimester, okay, and 10 millimeters in the third trimester. So anything below 4 millimeters in the second trimester is normal. Between 4 and 7, it's a matter of debate whether to consider it an upper normal, whether to communicate to the patient or not. And any measurement above 7 millimeters in the second trimester is a dilated renal pelvis. Lastly, it's extremely important to see the fetal urinary bladder. Okay, so here, if you have the Doppler and put the Doppler, you can see the two umbilical arches. But if you don't have the Doppler, anyway, the visualization of the urinary bladder is of paramount importance, because there are some malformation, and specifically one very important malformations, which presents only by a failure to visualize the urinary bladder, okay, which is the bladder extrophy. So if you cannot persistently see the urinary bladder, so if you do during the whole scan, you can never see the urinary bladder. Okay, this is an important reason to refer the patient to do a more detailed referral scan. Regarding the spine, well, the next lecture will be dealing specifically with the malformation of the central nervous system and the spine. But you have to, the minimum requirement is a longitudinal view of the fetal spine. The most used one is the mid-sagittal view. Okay? So whereas you can examine more, you can take more views to examine the spine, like the coronal view and the various axial views, but the indispensable important one is the sagittal view. And what you can usually see, what is described as a double railway sign. So you see two lines of vertebral structures. The anterior one is the vertebral body. The posterior one is one of the transverse processes of the vertebra. Okay? And you have to check for the integrity of the skin above the spine, and you should exclude the presence of any malformations at the level of the spine. The spina bifida will be discussed in detail in the central nervous system lecture. Limbs and extremities. So you have to check always that there are two femurs, you have to, and then that there are two legs, okay, and there are 2 feet, and then you go on the upper side and check that there are 2 humeri, that are the 2 forearms, and there are 2 hands. Okay? Counting the fingers is not obligatory in the ISWG mid-trimester scan guidelines. Okay? Although, of course, if you would like to count them and check for the fingers, for the finger numbers and shape of the hand, and which for the baby to open the hand, is of course it's something advantageous. If you can do it, but it's not obligatory. So this is how you see the leg, the femur, the knee, the tibia and fibula, and the fetal foot, and on the upper hand and on the upper image, the humerus, the forearm, so ulnar radius, and the fetal hand. So this is in a dynamic way how you should see the fetal foot. Okay. Of course, you can see it in a coronal view, and you'll check for the two bones and the presence of the foot. But the sagittal view is the ideal one to exclude malformations of the foot, like the most common talipes equinovarus, in which you will never be able. So if you have a club foot, you will never see this image. You will see the leg and the sole of the foot in the same image, but you will not see this right angle between the leg and the foot. This is the forearm. Okay, so the radius and ulna, and you can see the 5 fingers, thumb, and other 4 fingers. Okay. So the placenta has been discussed in detail yesterday, I believe, that you should check for the location and its relationship with the internal cervical os. And if you cannot exclude, you cannot see the placenta, which is very far or decisively far from the internal cervical os by the transabdominal ultrasound, doing a transvaginal ultrasound is crucial, okay, in order to exclude the placenta. So you can miss any small or malformations, but you should never miss a placenta previa, because this can have serious consequences of on the health of the mother, the baby, and for your safety as well. Okay, and if you have if the patient has a history of uterine surgery and a low anterior placenta or placenta previa, you should consider the risk of placenta accreta and perform a meticulous examination to exclude signs of accretism. So finally, I will close again with the report of the attached to the ISO guideline, which I invite you, if you are not used, to leave a systematic report to the patient. You can prepare yours, or you can directly use the ISO guidelines, which definitely, if you're starting to perform the mid-trimester scan, or if you are not used to give a systematically report to the patient, I think it can be crucial in order to help you to get a systematic approach to the mid-trimester scan. And usually, once you're used to do a systematic approach, you do it automatically because you'll have the shape of the report in your head. But this will need time and training in order to not to miss any malformations due to inappropriate systematic examination of the fetus. So I think we finished actually in time. Maybe we're even 5 minutes ahead. So I would be happy if you have any questions. I don't know if I'll have to. Okay. Okay, so I cannot see if there are any questions. Do you have any questions? Please write if you have any question. Otherwise, I'll wait for a few seconds. And meanwhile, if you have any questions, please write them. Otherwise, we'll go to the second talk, the following talk.
There is one question, Dr. Allen.
Yeah, I'm sorry, I cannot see it. I don't know why I cannot see it. I see that there is one, but
in QA box. In
yeah,
QA box.
I'm clicking on it, but it's not does not open it. Okay. Yes. So it's about the dilated renal pelvis. Okay. So thank you, Reka, for your question. Maybe I'll check in the program if there is no lecture specifically on the renal pelvis. Maybe I can show you some videos tomorrow about dilated renal pelvis. So the dilated renal pelvis is it's one of the abnormalities that is described quantitatively. So you describe it once you take the regular measurements of the anteroposterior diameter of the renal pelvis. So this is where the renal pelvis should be measured. Okay, so if you're using, whether you're using 4 or 7 millimeters, it's okay. You just have to have a predetermined cutoff. And the chapter of the renal pelvis, once you have a dilated renal pelvis, the women should be counseled about the possible reasons. So the main two reasons, the main reasons for having a dilated renal pelvis, sometimes it's only paraphysiological. So with the ongoing of the pregnancy, it can improve, but it can reflect two pathological reasons. The first one is an obstructions or stenosis, okay, of the renal pelvis or of the ureter, or it can or stenosis at the level of the pelvic-ureteral junction. And the other big reason of having a dilated renal pelvis is a reflux, so vesico-ureteric reflux. In fetal life, it's impossible to be sure 100% about whether you have a dilated renal pelvis because you have an obstruction, whether at the level of the ureters or at the level of the bladder outlet, like the ureteric stenosis or obstruction. Okay? So you have to, women should know that these are the main reasons, but we cannot give them an 100% accurate diagnosis in fetal life. The other important point to discuss with the patient is the increase in the risk of chromosomal abnormalities. This depends on what the patient has been using, has performed in the first trimester for the screening of the chromosomal abnormalities. So if the patient has done a combined test, and the combined test has a very low risk, okay, it's extremely unlikely that the presence of pilectasis, a dilated renal pelvis, would make the risk high in order to recommend an invasive procedure. Okay, if the patient did not perform a mid-trimester screening, women should know that having a dilated renal pelvis in the second trimester is associated with a slightly higher risk of chromosomal abnormalities, and they should be counseled about an invasive procedure. Okay. Well, there is a question of Dr. Lal about the different anomalies of the fetal head. Actually, it's a huge lecture. Yeah, so if I'll check in the program if there is no lecture specific addressing this this chapter, we can consider adding if the time would permit.
Dr.
tomorrow.
Tracy?
Yes.
Would you like to say something, I think?
Yeah, well, I just wanted to let Dr. Youssef and the participants know there will be a discussion this morning on anomalies of the genitourinary tract, and I will discuss dilatation of the renal pelvis. But
wonderful.
So we'll have images to go with Dr.
Great.
Youssef, so that's actually a great tie-in. I love when lectures blend together.
Thank you so much. This is very relieving for me. Thank you, Dr. Fox.
Yes, Dr. Reka, would you like to say something?
Yeah, anyway, Dr. Fox said she'll discuss in detail. I would like to ask questions during her session.
Oh, sorry. Okay. Okay, Dr. Ali, you can carry.
Okay, thank you. So I believe there are no further questions, so I'd go ahead with the CNS lecture, if this is okay. Okay. Okay, so the second lecture will be about the fetal central nervous system, and this is another guidelines which has been updated very recently by the ISWG. So in September 2020, ISWG has published an updated guidelines of the screening for CNS abnormalities, and in the coming days there will be published the second part of the CNS guidelines, which will talk about the detailed examination of the fetal CNS and the neurosonogram. So what's the difference between doing a basic examination of the fetal CNS and doing a neurosonogram? Okay, so this is okay. So before going into the details, okay, we have to check for the basic views in which every fetus should be examined in the mid-trimester scan. Okay, so the basics examination of the fetal brain is performed exclusively and totally in the axial view. Okay, and this is consists in taking two main views: the transventricular view and the transcerebellar view. We have seen it in the fetal biometry, but we will talk about them in details today. And the last view in the fetal CNS is the sagittal view of the fetal spine. So, and we'll be talking about what is normal and abnormal in each examination. Okay. What about this is the basic examination of the fetal CNS. The fetal neurosonogram includes more detailed examination with more views. So the mid-sagittal view, the sagittal views, and the coronal views are essential to do a detailed examination of the fetal brain, which is not included in the basic mid-trimester scan, but this should be performed only when indicated. So the fetal neurosonogram includes the sagittal view, the parasagittal view, in which we can see the whole length of the lateral ventricle, and then the coronal view examined from anterior to posterior, so seeing the midline, the cavum septum pellucidum, separating the anterior horns of the lateral ventricle, and then we can see the occipital horns of the lateral ventricle in the coronal view. So what are the advantages of doing a neurosonogram? Definitely, we can exclude more malformations by doing a neurosonogram in comparison with the basic scan of the fetal brain, and mainly, for example, regarding the fetal midline structures. Many malformations regarding the corpus callosum cannot be demonstrated, or sometimes not even suspected, in the basic axial views. Malformation of the cerebellar vermis and the posterior fossa are extremely difficult to diagnose in the axial views, although they can usually be suspected. By doing the neurosonogram, you check always for both hemispheres. You can see better the cerebellar sulci and the cortical structures, and you do a detailed examination of the fetal spine. So whereas a single view, sagittal view of the fetal spine is sufficient for the basic scan, for the detailed scan, you should ideally do the mid-sagittal, the coronal, and an axial examination of the fetal spine. So when to do a fetal neurosonogram? Well, whether you are not able to see a structure that you should examine in the basic scan, so you refer the patient to a secondary level detailed scanning, or in case of a high risk of congenital malformation. So, for example, women with previous malformations, women with a high risk in the first trimester scan, which did not do some kind of detailed examinations. So if you have a high risk of congenital, women who administered teratogenic drugs in the first trimester, so high risk of congenital malformations, it's an indication to do a detailed congenital CNS examination. So what can we see as, let's go into the further details of the views of the fetal brain. So this is the first axial view that we have to see. So it's the transventricular view. And what we should see is the cavum septum pellucidum. It's a rectangular space separating the anterior horns of the lateral ventricles. We should see the midline, and the midline is interrupted by this rectangular structure, which is the cavum septum pellucidum. Okay, and posteriorly we should see the lateral ventricle, and we should see the which is usually filled by the choroid plexus. And then by going down, we see the fetal cerebellum. So we see the dumbbell-shaped structure of the fetal cerebellum, and the black space behind the cerebellum is the cisterna magna. What kind of malformations that we can see regarding the cavum septum pellucidum? So as to go into a magnified view, this is a rectangular view of the cavum septum pellucidum, midline, and the anterior horns of the lateral ventricles. And you can see very clearly, you should see very clearly this rectangular space separating the anterior horns of the lateral ventricle. The cavum septum pellucidum, it's very difficult to see it before 18 weeks. And even if you do not see it before 18 weeks, you are not sure if you cannot exclude any malformation on the level of the cavum septum pellucidum. And usually much later in pregnancy, it is obliterated. So you have to know that in order to comment on the case of cavum septum pellucidum, ideally you should do it in the mid-trimester scan, so between 18 and 22 weeks, whereas of course it's seen further in pregnancy, but the more you go in advanced stage of pregnancy, it's more obliterated. And these are various examples of an abnormality of the cavum septum pellucidum, in which you cannot see the structure that has been described, like with the criteria that makes you describe it as a normal cavum septum pellucidum. So here you can see some kind of rectangular space, but it's not filled with a liquid, and it does not separate the anterior horns of the lateral ventricles, which are much more distant and anterior. And in the other three images, you cannot see clearly the cavum septum pellucidum. In the fourth image, you can see some space, but it's not separating the anterior horns of the lateral ventricles. So this cannot be described as a normal cavum septum pellucidum. And these are the three main abnormalities that you can see on the level of the cavum septum pellucidum. So the first one, it's actually a quite easily diagnosis, which should not be missed, not even in the first trimester. So you cannot see the space filling the space between the anterior horns of the lateral ventricle, but you see a rudimentary cavity, so a big space, okay, filling the anterior part of the brain, okay, with very few brain tissue in that image. So this is spot diagnosis. This is A-lobar or severe A-lobar holoprosencephaly. Okay. Sometimes the diagnosis is and the finding is a little bit more difficult to identify easily. Okay, so in this case, the only abnormalities that you can see on the axial view, okay, is that you do not see this rectangular space separating the anterior horns, and you can see a fusion between the anterior horns of the lateral ventricle. Okay, and we will go into the details because you cannot do the diagnosis, the final diagnosis on this view, but you can describe that on the axial view you cannot see the septum pellucidum. And the last spot diagnosis that you can see on the axial view is the case of the agenesis, the complete agenesis of the corpus callosum. So in the complete agenesis of the corpus callosum, you cannot see this rectangular space filling the space between the anterior horns of the lateral ventricle. Actually, you see only in line. Okay, you see the anterior horns of the lateral ventricle much more distal from the midline, and you see usually a mild ventriculomegaly and what's called a teardrop lateral ventricle. Okay? This is a classical view of the complete agenesis of the corpus callosum, and they all look the same. So if you have a complete agenesis of the corpus callosum, almost always this is what it looks like. The alobar or severe holoprosencephaly usually can be diagnosed from the first trimester. So this is the fetal head in the first trimester. You can see the midline, the choroid plexus. Okay? Whereas if you have a case of severe holoprosencephaly, usually almost always you see a single cavity and a single fused choroid plexus and an absent midline. And often they are associated with facial abnormalities. So the ultrasound finding of a fused anterior horns of the lateral ventricles. So what is the differential diagnosis? So it can be only an isolated agenesis of the septum pellucidum. Sometimes it's a consequence of a more severe malformations like an obstetric or obstructive hydrocephalus. Schizencephaly. Schizencephaly is when you have a cleft, so you have a damage to a part of the fetal brain. So if the damaged part includes the space between the anterior horns, schizencephaly can sometimes mimic an isolated agenesis of the septum pellucidum. And finally, mild cases of holoprosencephaly, which is lobar holoprosencephaly, which can sometimes be a challenging diagnosis, especially in the second trimester. So this is a case of schizencephaly in which on the midline, you can see a space which mimic a fusion between the anterior horns. But if you go on another, by moving up and down in the fetal brain, you will see that the absence of the brain structures is much more extensive than the localized part of the space between the anterior horns. And this is a case of schizencephaly. So you have in which you have a cleft communicating the ventricular system with the subarachnoid space. Okay. Schizencephaly is here the cleft. You can see the cleft communicating the lateral ventricle with the subarachnoid space. This is the sagittal view, and on the left-hand side you have a coronal view. Schizencephaly usually is a consequence of an acquired brain damage, whether it's vascular or infectious. And the prognosis depends on the extent of the brain tissue involved. Let's go into the details of one of the difficult differential diagnosis of fused anterior horns of the lateral ventricle, which is the differential diagnosis between an isolated simple agenesis of the septum pellucidum. So you have all the brain formed well, but you only have the absence of the two membranes separating the anterior horns, and a more severe malformation, which is the lobar holoprosencephaly. And you can differentiate them mainly by more detailed examination in the coronal and the sagittal view. So the upper three images are the case of a lobar holoprosencephaly. The lower three images are the isolated agenesis of the septum pellucidum. Okay? So you can see that the midline is very well respected in the coronal view. In the case of the isolated agenesis of the septum pellucidum, the midline is not that distinguished in the case of lobar holoprosencephaly. Okay? And more importantly, in case of an isolated septal agenesis, the corpus callosum and the midline usually is untouched, so it's normal. Whereas in case of the lobar holoprosencephaly, the corpus callosum is usually invisible or it's very dysplastic and irregular. Okay. Okay. So this is a case of an agenesis of the septum pellucidum, and you get the midline, and you see a perfect corpus callosum. So this is a case of an agenesis of the septum pellucidum. And this is another case in which you can see well in the axial view the fusion between the anterior horns of the lateral ventricle. Well, we say an isolated agenesis of the septal pellucidum, but we have to consider that when we see a fusion of the anterior horns of the lateral ventricle, and we do not see any other malformations, okay, there is a likelihood to have what is called the septo-optic dysplasia, or the syndrome of de Morsier, and which includes an abnormality of the optic tracts and the neurohypophysis. By ultrasound, the hypophysis and the optic tracts are quite difficult to visualize reliably. Sometimes the MRI can be helpful, especially if you go into the late second trimester or in the third trimester. The septo-optic dysplasia, the problem is this: it's associated almost always with important visual impairment and with global hypopituitarism, although the IQ usually is normal. Okay. So what about the examination of the corpus callosum? This is a technical, practical video on how to see the corpus callosum. So the corpus callosum is a midline structure. So in order to obtain a satisfactory image of the corpus callosum, you should get the mid-sagittal view, okay? And you have to use the acoustic windows in the fetal skull in order to visualize the midline structure. So if you take the view of the midline from just in front of the fetal face, okay, all the ultrasound echoes will be reflected and will not penetrate well into the midline of the brain. In order to take an appropriate view of the fetal brain, you have to go from the anterior fontanalis. So you have to go up, okay, with your transducer, not in front of the fetal face. And this is an example on how, if you, on the movement that you have to do. So you're getting a midline of the fetal face and you cannot see well the fetal structures. What you have to do in this case is just to move, okay, slide the probe towards the upper part of the fetal head to get the midline view. So just you have to move very slightly to get a view of the corpus callosum. Okay. Another technique, if you start from the coronal view of the fetal brain and get to place the midline of the fetal brain totally vertical, and you see the cavum septal pellucidum, and you see the anterior horns of the lateral ventricle. From this view, if you just move 90 degrees, rotate the transducer by 90 degrees, you will get an appropriate view of the corpus callosum. Okay. So how can we see the malformation of the agenesis of the corpus callosum? Well, we have just touched on that at the beginning of the lecture. So in case of an total agenesis of the corpus callosum. You cannot see the cavum septa pellucidum. You see a distanced anterior horns of the lateral ventricles, and you see a teardrop form of the lateral ventricle, and almost always it is associated with a mild ventriculomegaly. So this is a case, another case of agenesis of the corpus callosum, and they look strikingly the same. Okay, using different machines, different qualities of the machines, and the complete agenesis of the corpus callosum look always the same. An absence of the cavum septa pellucidum, distanced anterior horns of the lateral ventricle, and teardrop shaped of the lateral ventricles of the fetal brain. What about the outcome? Well, this depends primarily if there are associated malformations. So if you have an agenesis of the corpus callosum and any other malformation, the prognosis usually is very bad. Mild ventriculomegaly is not considered as an additional malformation in case of agenesis of the corpus callosum. It makes part of the diagnosis. So having a mild ventriculomegaly does not worsen the outcome of agenesis of the corpus callosum. If it is an isolated form, in 70% of these cases, babies will have a normal intelligence between 3 to 11 years. This is the follow-up reported in most of the literature. And there are some evidence that these babies, with the progressive growth, they have a progressive decline in their intellectual performance, and many of them necessitate targeted school support. So let's go to the posterior fossa, which is the last part of the fetal brain. So the posterior fossa is examined in the basic scan in the axial view. So you see the cerebellum, you see behind the cerebellum the cisterna magnum, and if you just go slightly below the just a few millimeters below the view of the dumbbell shaped, okay, you will see this image, okay, so of a black spot, okay, in front of the cerebellum, and then you see the black space of the cisterna magna, and you see a white structure, okay, connecting the two hemispheres of the cerebellum and separating what's in front of the cerebellum, which is the fourth ventricle, and what's behind the cerebellum, which is the cisterna magna. So by seeing this view, just moving a few millimeters down, you already have a very reliable image of an intact posterior fossa. Okay? And so this is on the left-hand side, the axial view, and on the right-hand side, you can see the mid-sagittal view of the posterior fossa. So you can see the cerebellar vermis. In front of the cerebellar vermis, you can see the fourth ventricle. Behind the cerebellar vermis, which is the part of the cerebellum, the much central part of the cerebellum, okay, it's lies between the fourth ventricle and the cisterna magna. Okay, and normally in the second trimester, the cerebellar vermis is quite down rotated, so it's lying almost attached to the brainstem. What are the abnormalities that can be seen at the level of the posterior fossa? Usually, there are two main groups. Okay, the first one is having a small cerebellum. Okay, so this is usually if it's below the cutoff for gestation age, it raises the suspicion of a cerebellar hypoplasia. Okay, and from a subjective evaluation point of view, okay, usually the malformation of the posterior fossa consists in having too much liquid. Okay, so you see spaces that are bigger than what's expected. Okay, or you see spaces, black spaces, where there should not be black spaces. Okay, so the first one is an increased space of the cisterna magna. So if you have the anthropoid diameter of the cisterna magna above 10 millimeters, this is a cisterna magna which is too big. Whereas the second important malformation at the level of the posterior fossa is a communication between the fourth ventricle and the cisterna magna. So I'll go back onto the normality. Okay? So normally, if you go down on the posterior fossa, you see the fourth ventricle, the cisterna magna, and you do not see a communication between these two spaces because this space is filled by the cerebellar vermis. Okay? Whereas an ultrasound finding is the communication between the fourth ventricle and the cisterna magna. This is not a diagnosis. This is an ultrasound finding which can be associated with more than one malformations, and sometimes it is a normal variant, but you cannot exclude or confirm any diagnosis at the level of the posterior fossa by only seeing the axial view. So what are the malformations that are associated with a communication between the fourth ventricle and the cisterna magna, what we can call here an open fourth ventricle? So you don't see a fourth ventricle that is closed with the cerebellar vermis separating it from the cisterna magna. You see an open fourth ventricle, which is communicating with the fourth ventricle. Well, the first and most common cause of having an open fourth ventricle, what's called the Blake's pouch cyst, or in the most recent publications, it's called simply an upward rotation of the cerebellar vermis. Okay? In the Blake's pouch cyst or the upward rotation, an isolated upward rotation of the cerebellar vermis, you can see the cerebellar vermis, which is intact, okay, of normal dimensions. So you can measure whether the vertical diameter of the cerebellar vermis or the surface area of the cerebellar vermis, and there are reliable charts for that. Maybe I'll share it with you, the reference, so that if anyone is interested to apply it in suspected cases, it's very extremely useful. The rotation of the cerebellar vermis is only slight, so and there are some angles that can be measured between the cerebellar vermis and the brain stem. If you, in the case of Blake's pouch cyst, the rotation between the brain stem and the cerebellar vermis is almost always less than 30 degrees. Okay? Whereas in Blake's pouch cyst, the outcome is almost always good. Okay? The second differential diagnosis is the vermin hypoplasia. So in the vermin hypoplasia, objectively the dimension of the cerebellar vermis are small, okay, and the rotation of the vermis and the brainstem is more than 30 degrees. Okay? And lastly, the last diagnosis, differential diagnosis, is the Dandy-Walker malformations. In the Dandy-Walker malformation, you have an hypoplastic cerebellar vermis and a severely rotated, okay, vermis and tentoria. Okay, so to summarize, the Blake's pouch cyst, or the isolated upward rotation of the cerebellar vermis, the dimension of the vermis are normal. Okay, the rotation is very slight, less than 30 degrees. In the vermin hypoplasia, the vermis is small and the rotation is higher. It's usually between 30 and 45 degrees. Whereas in the Dandy-Walker malformation, the vermis is very small and the rotation is more than 45 degrees. So lastly, you have to know that in the second trimester, you should not, when you write a report on the posterior fossa malformations, okay, you should not write a diagnosis 100% with 100% certainties, because although by applying these rules, to in the different diagnoses, we almost always get the diagnosis right, but we still get some surprises in the third trimester. So sometimes we describe cases of an isolated upward rotation of the cerebellar vermis, and then in the third trimester we see that the condition has worsened, so it changed the diagnosis. So the vermis has become much smaller and the rotation has increased. So this is increased the suspicion of a more severe malformation, and vice versa. Sometimes we suspect a vermin hypoplasia, and then by going in third trimester, we see that the growth of the vermis is satisfactory. So beware not to write an 100% diagnosis, but you describe what you're seeing and see report as the most likely diagnosis on the base of your findings, and you talk with your radiologist, because the MRI can sometimes be helpful in the diagnosis of the cerebellar malformation in general, and in the posterior fossa abnormalities in particular, usually in the late second trimester and in third trimester. Okay, what about the lateral ventricles measurements and ventriculomegaly? So actually ventriculomegaly is one of the most common abnormal findings of the fetal brain, and in order to avoid wrong or misdiagnosis, you should standardize the measurement of the cerebellar vermis of the lateral ventricle. So the lateral ventricle should always be measured at the level of the parieto-occipital sulcus. So this is the occipital lobe of the fetal brain, and this is the beginning of the parietal lobe, and the sulcus between the occipital and parietal lobes, okay, is the place in which you should measure the posterior horn of the lateral ventricle, and you should measure it perpendicular on the axis of the lateral ventricle. So you should measure it at the level of the parieto-occipital sulcus, perpendicular to the axis of the posterior horn of the lateral ventricle. The cutoff to define a normal posterior horn of the lateral ventricle is 10 millimeters. So any measurement beyond 10 millimeters is defined as ventriculomegaly, whereas mild ventriculomegaly is between 10 and 12 millimeters, and usually the vast majority of mild ventriculomegaly are associated with a very good outcome. But the causes of ventriculomegaly are quite various. So it can be, as we have seen, can be part of a more complex malformation like the agenesis of the corpus callosum, hollow prosencephaly, open spina bifida. Sometimes intraventricular hemorrhage are one of the main findings is ventriculomegaly, and in some cases of agenesis of the septum pellucidum. How should we manage ventriculomegaly? Definitely having a ventriculomegaly is an indication for a detailed scan. Okay? You should do the screening of the torch screening, the toxoplasma, cytomegalovirus, considering a karyotype and invasive procedure is to be considered. Okay? MRI should be offered if you have a radiological center with experience in examining the fetal brain, and usually they are helpful in more advanced gestation age, so from the late second and third trimester. The mild ventriculomegaly, especially between 10 and 12, are associated with a very good outcome, but in general, even up to 15 millimeters, the intellectual function is normal in almost 90% of cases in the pediatric age. So as I have anticipated in the beginning of the mid-trimester scan lecture, beware about the fetal brain malformations when you counsel the patient after the mid-trimester scan, because many brain malformations can be seen exclusively in the in late in pregnancy and sometimes only after birth. Okay, especially which are developmental abnormalities like atrophy, periventricular leukomalacia, hemorrhage, and many infectious causes of the fetal brain damage can are associated with a perfectly normal second trimester scan. So women should know that although a mid-trimester scan, a normal mid-trimester scan is extremely reassuring and reduces significantly the risk of having a problem, it does not work in 100% certainty way to exclude many malformations, especially the brain malformations. So now we'll be going into the last part of the lecture, which is the examination of the fetal spine. Okay. So this is the minimum requirement of examining the fetal spine, which is the sagittal view, in which we see the double railway sign, which is the anterior part is the vertebral body, and the posterior part is the one of the two transverse processes of the vertebral bodies. And if you get a perfectly midline view of the fetal spine, okay, you will not be seeing the double railway sign because you have two transverse processes. If the ultrasound beam passes exactly between them, okay, they will not be reflected and will pass directly to see the fetal spinal cord and the vertebral processes. So if you get the double railway sign, it's excellent. But if you try to get exactly the midline to see the spinal cord, okay, which ends with the conus medullaris and the coda equina, okay, so you see this pointing, okay, structure in the spinal canal, which is the spinal cord, and the conus medullaris usually ends in the mid-trimester at the level of the second lumbar vertebra, so at the level of L2. And another view for a detailed examination of the fetal spine is the axial view. So this is how we can see the axial views of the vertebra. Is this the vertebral body, the two transverse processes, okay, and lastly a coronal view. This is the coronal view of the fetal spine. So the three views: the sagittal view, the mid-sagittal view in which you can see the conus medullaris, the coronal view in which you can see the fetal sacrum very well, the lumbar vertebra and thoracic vertebra, okay, and a detailed examination of the axial views of the fetal spine. So, spina bifida. So there are spina bifida, of course, is the most common malformation on the that can happen at the level of the fetal spine, and there are two main types of spina bifida which are extremely different from a prognosis point of view between each other. The first one is an open spina bifida. The second one is a closed spina bifida. Okay, what's make the difference between an open and a closed spina bifida is the presence or absence of fetal skin. Okay, so in a closed spina bifida, the malformation, the defect of the spina bifida is covered by skin. So there is a defect of closure of the fetal spine, but this defect is covered by skin. Whereas in open spina bifida, there is a neural tube defect at the level of the spine. So there is a defect in the closure of the fetal spine. And this defect is not covered by skin. The defect can be cystic or can be non-cystic. So in case of cystic open spina bifida, usually the name is myelocele. Yeah, I'm sorry, myelomeningocele. Whereas in the case of an uncovered defect, the diagnosis usually is myelocele. There is not really an important significant difference from an outcome point of view between the cystic and non-cystic open spina bifida, but definitely there is a huge difference between the outcome of open and closed spina bifida. Okay? Fortunately, in cases of open spina bifida, there is always some kind of alteration of the fetal brain anatomy. Okay? Whereas in cases of a closed spina bifida, which is associated with a much better outcome, it is usually asymptomatic or associated with very slight abnormalities. Okay? And the brain is intact. Okay? So the open spina bifida is associated with a very high risk of neurological abnormalities like lower limb paralysis, incontinence, and hydrocephalus. And from a prenatal diagnostic point of view, we can always see some kind of alterations on the level of the fetal brain, and we'll see that in a few seconds. So again, this is the difference between the cystic and non-cystic open spina bifida. The open spina bifida, the cystic form is usually called myelomeningocele, okay? Whereas the myelocele, you cannot see the cystic, it's non-cystic, and sometimes it can be a little bit challenging to see accurately the defect, but fortunately you will always have these signs at the level of the fetal brain if you have an open spina bifida. So what happens in an open spina bifida, okay, that because there is no skin coverage, okay, the cerebrospinal fluid leaks from the spine. This reduces considerably the pressure inside the spinal canal, okay, and which leads to a prolapse of the fetal cerebellum inside the spinal canal. So there is an obliteration of the retrocerebellar space, okay, and a deformation of the shape of the fetal cerebellum. So it's not a dumbbell shaped anymore, but it have this banana shaped structure. Okay, so having an obliterated posterior fossa with a banana shaped cerebellum, and the other criteria that you can see alteration of the fetal skull structure that you can see in the cases of open spina bifida is that due to reduction of the pressure inside the fetal skull, there is an inside anterolateral retraction of the fetal bones, of the fetal skull bones, what gives the brain this funny shape called as a lemon sign. So you see that there is an alteration of the anterior part of the fetal skull bone, okay, and the fetal skull has a lemon shaped form. Okay? So in case of open spina bifida, the banana signs, so an obliteration of the posterior fossa, and a curved shape, a prolapsed cerebellum, and a lemon shaped skull are persistently present criteria in case of open spina bifida. Okay. So the normal cisterna magna should be between 2 and 10 millimeters. In cases of open spina bifida, this is obliterated, so you have an absent or a very small posterior cisterna magna. Okay? And whereas if you have an enlarged cisterna magna more than 10 millimeters, okay, this is a mega cisterna magna. A mega cisterna magna, if it is isolated, it is definitely an indication to do a detailed scan, okay, and so a secondary level scan to check both for intracranial and extracranial abnormalities. And in case of isolated megacisterna magna, the outcome usually is very good. What about closed spina bifida? Well, closed spina bifida is a challenging, often a challenging diagnosis, okay, because you have a normal intracranial structures, okay, and you have defects that sometimes are quite small, okay. Fortunately, the vast majority of closed spina bifida, so spine defects of the closure of the spine, which are covered by skin, the vast majority are associated with an excellent outcome, okay. The only exception, okay, when you have a tethering of the cord inside the defect. So what is the cord tethering in case of closed spina bifida? Okay. So the vast majority of spina bifida, of closed spina bifida, have a free spinal cord. So you have the spinal cord, you see the conus medullaris finishing in a like a bird's beak shape, and then you see the space of liquid, okay, between the behind the conus medullaris and the filum terminal. So this is a normal free spinal cord. Whereas if during the growth of the baby, the formation of the baby, the cord has been anchored, so has been attached to the defect of the closed spina bifida, okay, what happens is by the growing in the length in the length of the baby, okay, the spinal cord gets increasingly stretched, okay. So due to this stretching, okay, can result in ischemia and a progressive deterioration of the neurological outcome of baby. And this is definitely an indication for a surgical intervention in the postnatal life, and it's definitely a neurosurgical evaluation. But in case of a tethering cord, from our point of view, what we can see that is that you see in the spinal cord, which does not end at L2 like it ends normally, but you cannot see the end of the spinal cord, and you see it going downwards towards the defect, and it's attached there, and you do not see a free end of the spinal cord. So these are two cases of a tethered cord in which you see the spinal cord going towards the spinal defect, and it's anchored into the defect. So this definitely can help in counseling the woman. If you see the free spinal cord, we can say that most probably this baby will not have any neurological symptoms and probably not even need to get operated in any urgency, and probably not at all. Whereas if you have a tethered cord, it should be reported that we see an cord that is not free and is anchored to the defect, and that most probably it will need a surgical intervention in order to free the cord from the defect. So we started by the basic examination of the fetal brain, about the basic views, and then we have gone into details into much more sophisticated diagnostic aspects. So what can we do every day in order to improve our examination of the fetal CNS? Definitely the basic examination, so the transventricular view, the transcerebral view are essential. You cannot do a mid-trimester scan if you're not able to get them systematically. In addition to the midline view of the fetal spine. You can improve your diagnostic accuracy by trying to get the midline view as often as you can. You can try to get always to see the both ventricles and to do a detailed examination of the neural tube, so of the spine from the cervical, thoracic, lumbar, and sacral components. And if you be able to add the coronal view and the axial view of the fetal spine, that can help you to improve your diagnostic accuracy and the appropriate diagnostic investigation, or in case of a suspected malformation of the fetal spine. So that's the end of my second lecture. I apologize if I went into a lot of details. Maybe it sometimes can be a bit sophisticated, but I'll be happy to get your questions if you have any. Okay. Okay, I can. Okay. Okay, Dr. Rika Gadam is asking about the choroid plexus cyst. So the choroid plexus cyst, okay, is quite a common finding. Okay, now in the era of the first trimester screening, yeah. Our main worry in the presence of the choroid plexus cyst and the first studies reporting on the relevance of choroid plexus cyst was the association between choroid plexus cyst and chromosomal abnormalities, especially trisomy 18. Okay. The issue is that with chromosomal abnormalities, especially trisomy 18, it's almost impossible to have only isolated choroid plexus cyst as the only finding. Okay, and now in the era of the first trimester screening for chromosomal abnormalities, with the combined test, and even more now with the increasing access to the fetal free, the NIPT, the cell-free fetal DNA. We do not give any weight anymore to choroid plexus cyst. Okay, and many operators actually do not even report it. Okay, when you see a choroid plexus cyst, whether unilateral, whether bilateral, whether including the posterior horn, whether including only also the anterior horn choroid plexus. The idea now is that it is almost always a normal variant. Okay, so we usually reassure the patients when we have an isolated choroid plexus cyst. Okay, that it's a normal variant. The maybe a relevant question would be whether women, fetus with an isolated choroid plexus cyst, not screened for the first trimester, whether they deserve to have a secondary level detailed scan. I think that would be advisable. Okay, there is no consensus about it, but I think that if you're doing only basic scan, mid-trimester scan, and you see choroid plexus cyst in a fetus which has been screened in the first trimester, I think that it would be wise to send the woman for a second for a detailed scan. So in a secondary level scan. Can you show where to measure the angle, normal, abnormal, the vermis, brainstem? Okay. Well, Dr. Almas is asking about how to measure the angles. I'm sorry that it was not present in that specific lecture, but I think that I should we have it here. So what are the measurements that should be performed on the level of in case of suspected fetal posterior fossa malformation? Okay. So these are the angles. So there are two angles. The first angle is the brainstem Vermes angle, which I think this is the most important one. Okay, and okay, so the first angle is the angle one. I would consider only this angle because it's the most reproducible one. So, and these are the so you trace two lines. The first line is on the posterior aspect of the brainstem, and the other angle is running through the anterior surface of the brain vermis. And these are the data of the study that we have conducted on 3D volumes performed in cases of normal and suspected posterior fossa abnormalities. Please consider these data, but do not use them as an absolute 100% categorization of the posterior fossa abnormalities. Although they perform very well, they do not perform in 100% accuracy way. So in case of normality, okay, almost all cases, actually all normal cases had an angle less than 20 degrees. Okay? Whereas in the Blake's pouch cyst, all cases had an angle less than 30 degrees. So this means that if you have an angle less than 30 degrees, it's whether normal or an Blake's pouch cyst, which is an isolated upward rotation of the cerebellar vermis. This means that in angle, the brainstem vermis angle is associated with a very good outcome. Okay? Whereas the vermin hypoplasia and the Dandy-Walker malformation, which are the two pathologies with an almost invariably bad outcome, had an angle more than 30 degrees. And the Dandy-Walker malformation, which is the worst diagnosis, were systematically associated with an angle more than 45 degrees. Okay, so I hope this answers the question of Dr. Almas. Is that true for all Dandy-Walker malformations? I don't know what do you mean by all Dandy-Walker malformation, but usually, probably you are referring to what's the old terminology of Dandy-Walker variant, okay, which is obsolete. Okay, so Dandy-Walker malformation is only one malformation, is the Dandy-Walker malformation. Okay, and then you have, so these are the malformations that have normal. You have an upward rotation of isolated upward rotation of the cerebellar vermis, what has been called till recently and now till now some studies with Douglas Blake's pouch cyst, and then you have the vermian hypoplasia, what has been called in the past by some studies as the Dandy-Walker variant. Okay, but this is obsolete in all the new literature. So the Dandy-Walker malformation is a one malformation, the Dandy-Walker malformation. Okay, so the Arnold-Carey malformation, Dr. Poonan Lal, is the Arnold-Carey malformation. The Arnold-Carey malformation is the prolapse of the cerebellum into the spinal canal. So the Arnold-Carey, okay. Okay. I'll get back to the lecture. Okay, so what happens in the open spina bifida? This the fluid escaping from the defect, the prolapse of the cerebellum inside the spinal canal. This is the Arnold Carey malformation. Okay. I guess that there are no further questions. If you will be meeting Saturday, so if you have you would like to elaborate any questions for the next time, I'm confident that we'll have time to discuss further questions on Saturday. If you'll have time to read the guidelines, the mitral scan and the fetal CNS examination guidelines. And if you have further questions, I'd be happy to answer them when we meet Saturday. So I think I'm almost in time. Am I, or I'm in delayed or am I in?
Yes, you are on time. Thank you, Dr. Ali.
Yeah. Thank you so much, Yassine, and I'll Dr. Tracy. Hi, nice to meet you.
Nice to meet you as well. Thank you.
Thank you. So I'll give the microphone back to you, and I'll be happy to listen to the lecture.
Wonderful. Thank you. And if you'd please unshare.
Yeah, I'm sorry.
No,
Right.
You're fine. Hi, everyone. Marhaban. Welcome back. And for those of you that were here yesterday, I have an answer to a question that I did not have a slide for yesterday. That was intentional that I didn't have the slide, but I still wanted to show it. So let me share my screen and bring up my talk. This talk is sort of a follow-up to yesterday's talk on fetal biometry and fetal growth restriction. Today, I'll talk about the Doppler aspect of fetal growth restriction and some other areas of Doppler. For those of you that were not here yesterday, my background is as a sonographer in the United States with almost 30 years of ultrasound scanning experience, much of it in perinatology. And as a sonographer, as you may know, we don't make the diagnosis. If the physician does that, but we work very closely with the physicians. And also in my role as an educator at Thomas Jefferson University, I am an expert in ultrasound physics. I have a textbook on ultrasound physics. And so with every lecture I give, you'll always find some physics. I can always find a place to put some physics, and you'll find some in today's talk as well. So first, an ultrasound time machine. I want to jump back to yesterday's placenta talk. Somebody had asked me about placental grading. I don't know if you're here today. And my slide, you know what? My slide disappeared because I still have it hidden. I had it hidden in yesterday's talk, and I need to unhide it so we can see it today. So the reason why the slide was hidden, as I mentioned yesterday, was because we no longer comment on placental grading. But if you wanted to have a scale, here it is. It's grade 0, 1, 2, 3, 0, no calcifications, up to grade 3, which is complete separation of the cotyledons. So again, as I mentioned yesterday, there's no bearing on grading of placenta, except that if you had advanced grading of a placenta, for example, what would be called a grade 2 placenta, or a significant number of calcifications and an indent in the chorionic plate at 20 weeks, that would be concerning for FGR and aneuploidy potentially. But now I will take you back to your regularly scheduled lecture, and I hope that answered your question. So some, not all of this talk is based on the ISUOG practice guidelines that came out in 2013 for Doppler ultrasonography in obstetrics, and not much has changed since then as far as how to practice Doppler. It's a technique that's been around for quite a while. We have some new tools in the toolbox that I do not go into today, like superb microvascular imaging, SMI, which may offer even more information about slow flow and things like that. But first, let's just look at a brief review of the anatomy. The placenta, of course, is that life-giving organ that supplies nutrients and takes away waste from the fetus. The placenta offers its blood in a passive form and sends its oxygenated blood through the umbilical veins, right? So this is one of those strange cases where you have oxygenated blood in a vein, and it travels just in a smooth or very minimally pulsatile, but usually just a smooth version all the way into the heart. And because the liver doesn't do a whole lot of work in the fetus, much of that blood is shunted away from the liver through what's called the ductus venosus, and we're going to talk about that, directly into the SVC and into the right atrium of the heart. The heart is a pump, and as such, it pumps its deoxygenated blood through the umbilical arteries, which come out about the iliac veins, or the iliac arteries, but the umbilical arteries come out of the iliac arteries. And again, this is deoxygenated blood at this point, but it's pulsatile because it's coming from the heart, and the umbilical arteries carry the blood to the placenta. Blood flow through the placenta is blood flow through the umbilical arteries. It's not even that early here this morning, and I've already had coffee, but I can't talk. Blood flow through the umbilical arteries is a direct measure of how the placenta is doing. The placenta should be fluffy, billowy, like a handful of cotton balls or a soft pillow. I'm just trying to give you something in your mind to envision. It should be welcoming of blood. It should say, please give me blood in systole, give me blood in diastole. And it should be very, very welcoming to receive blood. When the placenta has issues, whether those issues are caused by a hostile uterus or aneuploidy or some other condition, some reason, maybe something wrong with mom, maternal hypertension, but if there's a reason for that placenta to become less friendly, it increases its resistance to that umbilical artery blood, and we can see that in the waveform. So the waveforms are very important, not just the measurements, but the mere shape of the waveform can give us information. So let's move on. Just a review from yesterday for anybody that wasn't here yesterday. Early FGR or symmetric FGR, fetal growth restriction. I know it's also called intrauterine growth restriction, IUGR. The current ACOG recommendation is for FGR. Represents only about a third or less of fetal growth restriction. And this one is the one that occurs early on before 32 weeks, is more likely to be associated with aneuploidy or congenital anomalies like open neural tube defects, etc. Intrauterine infection, we talked about CMV and other torch infections yesterday, multiple gestations, which is automatically high risk, and a previous history of fetal growth restriction is also a risk factor. Symmetric fetal growth restriction can also be idiopathic, and we don't know why it happens. Again, maybe it's just a uterus that didn't want to be pregnant. We don't know. With early, and I'll call it early FGR, the HC to AC is normal. That's because everything is small. The baby is small in all body parts. And there may be oligohydramnios. And yesterday we talked about the difference between small for gestational age and symmetric FGR, both of which are less than the 10th percentile. The difference is FGR is pathologic and therefore goes with low fluid and abnormal Dopplers, and small for gestational age is usually constitutional and not associated with any other adverse factors. The fetus may have an abnormally calcified placenta, and at least in the United States, by ACOG recommendations, only the umbilical artery Doppler consistently is predictive of outcomes. So there are other Dopplers, all of which we're going to talk about today. But note that most of them have a low positive predictive value and are not consistently reliable when documenting fetal growth restriction. But the one that is consistently reliable is umbilical artery Doppler. And ISUOG does mention that in their guidelines. Late FGR is the rest of the FGR cases, 70 to 80%. So most cases are late FGR. And this occurs in the last 8 to 10 weeks of pregnancy and is usually from placental insufficiency. So again, a bad placenta for whatever reason. And this is commonly associated with hypertensive disorders of pregnancy. In late FGR, there will be a discordant HCAC with the AC greater than 2 weeks behind the head. And this is because due to different shunting mechanisms that occur, there's increased cerebral perfusion, and this is what causes the so-called head sparing or brain sparing FGR. And what happens is, as we'll show you shortly, there's a decrease in the resistance in the middle cerebral artery as the brain says, I don't know what's going on here, but I need more blood. And so the arterioles in the brain dilate, the arteries in the brain dilate, and more blood goes to the head. So the head ends up having a normal HC and the belly falls off, meaning it decreases in size. And the umbilical artery is, again, predictive of what's going on with the placenta. So that's what we really want to follow. So Doppler and well-being, we're going to look at the umbilical artery Doppler, which has a role not only in placental insufficiency and growth restriction, but isoimmunization and hydrops. We'll look at the middle cerebral artery Doppler, which again, I put growth restriction with an asterisk because again, it depends on what literature and what standards or guidelines you follow. In the US, we are much more likely to use MCA Doppler for isoimmunization and hydrops. However, it doesn't mean nobody looks at it for growth restriction. And again, when there's head sparing or late FGR, there are labs that will use MCA Doppler, but all you're really doing is demonstrating what's already known to some degree, because at that point you already suspect late FGR. And keep in mind that what we measure between these two things here, growth restriction or hydrops, is different. And I'm going to mention that. And then the ductus venosus is another common one. Keep in mind, we can look at the ductus venosus as early as the first trimester. And there was a great talk yesterday on first trimester imaging. But we can actually predict heart disease in the first trimester with ductus venosus measurements. But that is outside the scope of today's talk. However, we are going to talk about the role of the ductus venosus in FGR, and also it's again commonly used in hydrops because it's associated with heart failure and overload. So as I mentioned, the placenta should be, and for lack of a better word, I'll call it fluffy. It should be light and airy and low resistance and, you know, again, something like a pillow. And it should allow for a lot of perfusion from the fetus. We need to send blood in systole. We need to send blood in diastole. So there should always be forward flow across the baseline. And this again allows for that nutrient, oxygen, and waste exchange between the mother and the fetus. So a healthy placenta would be a low resistance waveform in the umbilical artery described as monophasic flow. And I'm actually going to go over what that means. Again, throwing my physics hat on, and there actually have been some changes in terminology in the last year. As the placenta gets sick, as the placenta gets more calcified and it gets smaller and it gets what I call crusty, it will get reduced flow through it. The resistance of the placenta, now to some degree, age, gestational age, causes the placenta to get calcified, to get crusty, to get more resistant. And that's a normal part of the growth and development of the fetus and the placenta. However, when this happens prematurely, that adversely affects how much blood and oxygen the baby's getting. So as the placenta gets sick, especially depending on how early it is, that will affect how much oxygen the baby has and ultimately the outcome of the fetus. When there's placental insufficiency, there is increased resistance of the umbilical artery. Again, the umbilical artery tells us about the placenta. And so that's the key thing to think about. So there is a change in the spectral waveform to a more resistive waveform. Now there's two things we can describe when we talk about spectral waveforms. One is phasicity. How phasic is it? And we mean cardiac phasicity, not respiratory. And what is the resistance of the waveform? A monophasic waveform means flow is only on one side of the baseline. And so it's forward flow in all phases of the cardiac cycle. There's no reversal of flow. When we describe a waveform as being low resistance, we're saying that in systole, there's a prolonged downstroke and pandiastolic forward flow. Monophasic and low resistance are often used as synonyms. That's not always the case, and I'll show you what I mean by that. But generally speaking, the umbilical artery should be low resistance and it should be monophasic. A high resistance waveform has decreased diastolic flow compared to systolic flow, with a brisk upstroke to peak systole and a sharp drop to baseline. So with high resistance waveform, there may or may not be any diastolic flow. And if there is diastolic flow, it may even cross the baseline one or more times. High resistance flow is often described as being a multiphasic waveform. Let me show you what I mean. So last year, in an article by Kim and others, I have the link below, a consensus statement was drawn up. So a group got together and created an article and published an article with a new consensus agreement on what we should call these different types of flow. The old terms, triphasic and biphasic, were replaced with multiphasic. I often tell my students that the easiest way to start a fist fight at a vascular conference is to put a waveform up and ask people to describe it. And it gets ugly in the vascular world when we try to talk about waveforms. And that's what this article was designed to fix. So now, if you have flow that crosses the baseline and comes back again, or flow that just crosses the baseline once, it's called multiphasic. Again, there's no such thing as triphasic, biphasic. It's multiphasic. And whenever you have multiphasic flow, it implies a high resistance waveform. Monophasic flow is forward flow through systole and diastole, no reversal of flow. Now, the sticky wicket, the area of difficulty, gets to be when we're talking about resistance. Because, and again, this is where the fights would break out at the vascular conference. Somebody would put this waveform up and say, well, what is this? Is it monophasic or biphasic or what? Well, it's obviously monophasic because there's only forward flow in systole. There's no flow in diastole. But didn't some people say, well, monophasic flow is always low resistance? Well, no. So that's why you cannot say that all monophasic flow is low resistance. This is a high resistance waveform, but it is monophasic. When we talk about monophasic flow, we're usually talking about what you see here, that prolonged systole into diastole, and then a rise back up to systole. So when we talk about monophasic flow being low resistance, this is what we're talking about. This flow here would be abnormal in an umbilical artery, even though it's technically monophasic, but it's not low resistance. So again, what is the phasicity and what is the resistance? The good news is we don't have to qualify it. We're going to quantify it. There are numbers for all of this, but it is important to use your eyeballs when looking at these waveforms so that you know what you're describing. Intermediate resistance would be like when you have a lot of flow in systole, but only some flow in diastole. And so this is kind of a combination. This is what you would see, for example, in a common carotid artery, if anyone does vascular ultrasound. It's sort of a combination of high and low resistance. High and low resistance. And then the low resistive waveform is always monophasic. So this example here, flow in systole, flow in diastole. This waveform is actually abnormal in shape, something called tardus parvus, but since that doesn't apply to obstetrics, I don't need to discuss it here. Quantifying resistance. The three most common things we use in OB is the resistive index, or RI, often called, sometimes called the Porcello index, which is peak systolic minus end diastolic over peak systolic velocity, or A minus B over A is a nice easy way to remember it. The pulsatility or Gosling index, the PI, is peak systolic minus end diastolic over mean, or A minus B over mean. And the SD ratio is simply peak systolic divided by end diastolic. The good news about these ratios is the absolute velocity is not important. So when I talk about angle correction in a moment, that does not apply to these indices. You do not need angle correction when you do these indices, which is a good thing. The other thing is when you have your waveform up, today's modern day machines will do auto trace, which I'll talk about in a second. I always warn caution with auto trace. But if let's just say all you needed was an RI, then all you need to do is measure peak systole and end diastole, and the machine will give you an RI. But since we often look at more than one ratio at a time, what I would recommend is trace the waveform, whether you let the machine do it, or if you have an older piece of equipment, you manually trace the waveform. You'll get RI, PI, SD ratio, the heart rate, and a few other things you may not even need. So this is a chart for umbilical artery SD ratio, and this is readily available online. My source is from Kalen's, my favorite textbook on OBGYN from their 2017 edition. It hasn't changed much over the years. And so if you, here's the 50th percentile, and then you've got less than 10th and greater than 90th, less than 5th, etc. for umbilical artery ratio. The umbilical artery SD ratio does increase normally. As I mentioned, the placenta does increase in resistance as the pregnancy goes on. And so we would, but the resistance is higher when it's younger, and then it gets less resistive as it gets older. And then what you're seeing here is a decrease in the SD ratio as the pregnancy goes on. Note that there's no number greater than 4 that's normal. So anything over 4 on an SD ratio is always abnormal. The resistive index, and again, here you can see the resistance decreasing as the pregnancy progresses. And so here's the RI chart, and then the pulsatility index also decreases as the pregnancy progresses. So what we want to know with the umbilical artery is how resistant is the placenta, because the more resistance it has, the worse it is. And so as we do the Dopplers, it's very important to pay attention to the diastolic flow. So a normal waveform for the umbilical artery would be monophasic low resistance, forward flow in all phases of the cardiac cycle. And here they're picking up a piece of the umbilical vein that's not part of the artery. And the flow doesn't even come close to approaching the baseline. So if I did a PI on, or an SD ratio on this waveform, it would be normal. As the placenta gets more resistive, as the placenta goes bad and it becomes more resistant, you'll lose that diastolic flow. And this is called absent end diastolic flow. Absent end diastolic flow is a very concerning sign. Now, before that happens, the SD ratio, the RI, and the PI will start increasing in this vessel, so in this artery. So the umbilical artery will start increasing in resistance, and that's when maybe you start doing weekly Dopplers to pay attention to it. Once you get to absent end diastolic flow, you have to start planning when you're going to do delivery, because what you don't want to see is this next one, the reversed end diastolic flow. With absent end diastolic flow, the baby is only getting oxygen essentially during systole. Because it also, if you're not getting the flow out of the body because of increased resistance, that means you're not getting flow into the body. You can't just keep having the placenta send blood to the fetus and it's not coming out in all phases of the cardiac cycle. So therefore, again, the baby doesn't get enough, the fetus doesn't get enough oxygen. So this absent end diastolic flow is a very concerning sign, because the resistance of the placenta is to a point now where there's only enough pressure during systole to get blood into that placenta. And then the worst thing you could see is reversal of end diastolic flow. And now what you have, not only is the blood hitting the placenta, but the placenta is so resistive, it's bouncing back. So imagine running into a brick wall and you get thrown backwards when you hit the wall. That's what's happening here. The blood is hitting the placenta and some of it is getting kicked back because the placenta is so resistant. It's actually going back towards the fetus. This is a premorbid finding. You must consider delivery as soon as possible. And I'll show you one example of a case like this, but that you can stay pregnant with absent end diastolic flow as long as your other things, and we'll talk a little bit about them, such as the fluid, the non-stress tests, as long as those are okay. You know, doctors will keep patients pregnant with end diastolic flow, but once there's reversal, it's game over. Reversed end diastolic flow is associated with 70% destruction in placental arterial destruction, so the placental arteries. And there are differences in PI and RI depending on where you measure. So some authors say to measure it near the abdomen because that's where it's higher resistance. It's more conservative to measure there. But some authors say just use a free loop of cord. In my practice, we always used a free loop of cord. And again, towards the placenta will be lower resistance, towards the ACI is higher. Doppler of the umbilical artery can show early warning signs. So again, you may see signs of increasing resistance in the umbilical artery before there's other serious issues like a decrease in fluid. But these are signs of hypoxia in the fetus with growth, with potentially growth restriction. And again, I mentioned that reversal of the end diastolic flow, you need to deliver. The MCA, the middle cerebral artery, the ductus venosus, and other arterial measurements that are in the literature, at least in the US, are not considered reliable in predicting FGR, and I mentioned the low positive predictive value. There are findings that can be seen in the venous system that are seen with more advanced fetal compromise. Again, none of them having the positive predictive value of the umbilical artery, but again, things that we do need to focus on. The fetal heart is important with regards to hypoxemia and at birth fetal acidosis, and as it ties into growth restriction. So the MCA and the umbilical artery are the first vessels to become abnormal. As there are changes in the right-sided heart pressure, that will cause changes to the ductus venosus, the IVC, the hepatic veins, and potentially umbilical vein in cases of severe fetal growth restriction. So the recommendation is growth scans every 3 to 4 weeks with weekly Doppler and AFI. And depending on how severe the FGR is, they may do twice weekly Doppler and AFI along with the non-stress tests. Technical settings matter. As I said, I can throw physics into any lecture. One of the controls that nobody ever thinks about on their machine is the wall filter. And Dr. Simon yesterday mentioned about how important it is to be friends with your application specialist. And I want to reiterate that. The wall filter is a setting that is designed to eliminate clutter, which is noise along the baseline. What does that clutter come from? Usually from wall motion. So if, for example, in an adult heart, the motion of the myocardium creates a Doppler shift that we'll see along that baseline. And that we want to eliminate. Well, in obstetrics and gynecology ultrasound, and the same with liver ultrasound, you know, most ultrasound that isn't adult echo, there is very little artifact that occurs at that baseline that you would need a wall filter. Because when you turn the wall filter up, you're eliminating, flat out eliminating, the information that's along the baseline on both sides of the baseline. And so if there was useful diagnostic information there, and not noise, but actually useful information, you've just erased it. So this was a case that I had many years ago, and this was a woman who was 32 weeks pregnant with known fetal growth restriction. She had absent end diastolic flow, as you see here, but the fetus was stable. Now, at the time I did this ultrasound, I'm teaching full time, but I do per diem ultrasound, meaning I do it on the side for fun and a little extra money. So I was doing my, you know, once every couple months or once every month, I would do a day in perinatology. And this was one of those days. So I had never seen this patient before, but I knew her. I read the chart. I knew she had fetal growth restriction with absent end diastolic flow. And they said her non-stress tests are good. Her fluid is fine. As long as she doesn't change to reversal of the end diastolic flow, then we'll keep her pregnant because the baby's going to do better on the inside versus the outside. So I do the ultrasound and I say to myself, okay, good. There's still only absent diastolic flow, but then I see something in the image and I see this black line at the baseline. And again, being a physics person, I say to myself, why is there a wall filter on an obstetric ultrasound? And so I do what any good operator of ultrasound would do. I decrease the wall filter. Well, I swear to you, this is a true story. I'm not making this up for effect. When I took away the wall filter, look what I saw. Reversal of the end diastolic component. This is now a pre-morbid finding. So I immediately terminated the scan, politely left the room, and I went to the perinatologist and I said, there's reversal of end diastolic flow in Mrs. Smith. And he said, get her to labor and delivery right now. She delivered, I forget if it was that day or the next day, but she delivered immediately. There is a potential that she would have come in on Monday for her next ultrasound with a demise, with a 32-week fetal demise. So again, very important what your technical settings are. And we're going to review a few more technical settings just because I think they're important. And if this lecture goes over a little bit, the only thing I will say is that my next lecture will be shorter, so we can cut it off the back end. The spectral envelope is here, and I know one of the physicians mentioned this yesterday. So we have the spectral envelope, which is the white line. The area under the envelope is the window. And when your gate is small, your range gate is small for a pulse wave Doppler, and you're in the middle of a vessel, you'll get this nice open window, and we call this laminar flow. If your gate is wide open, or if there's a lot of turbulence or some other conditions, or if you're using continuous wave, you will have spectral broadening. Spectral broadening is not always abnormal. So there are normal times when we see spectral broadening, but I just want to point that out for terminology. Peak systolic velocity and end diastolic velocity are shown here. End diastolic velocity is almost always measured right before systole starts again. Doppler controls. Now there is a range gate in pulse wave Doppler, and you have the ability to place that in a specific vessel. If you are interested in absolute velocities, not ratios, but actual velocities, you must either use a 0-degree angle, which is the most common thing in obstetrics, or angle correct to flow. So for example, if you're doing an MCA Doppler on a fetus that is not in a perfect position, you may need to apply angle correction. And I'll talk more about that when we get to MCA Doppler, because that's really the only place that matters. On almost all the other vessels, we're only interested in ratios, in which case you do not need to worry about angle correction. It's only if you need absolute velocities and you can't be 0 degrees. If your angle correction is wrong, so let's say that MCA is not perfectly lined up at 0 degrees, but you don't apply angle correction, then your velocities are wrong. So when possible, use 0 degrees for any time you need to obtain a velocity. The same thing would apply to fetal echo. And the reason why we like 0 degrees is because that's the most accurate angle. The higher you get in angle, the higher you get in error. And we don't use, in the world of general and vascular ultrasound, doesn't really apply to OB. We don't use anything over a 60-degree angle because the degree of error is way too high. But in OB, we do try to use a 0-degree angle when possible. Another control that you're going to use is scale, also called PRF. And again, I think Dr. Simon mentioned it yesterday when he said to increase the scale to a certain level. The general rule is just increase the scale or decrease the scale until your spectral waveform fills up about 2/3 of the window. And then that's usually a pretty good starting point. If the flow is really fast, increase the PRF or scale. If you're having trouble finding flow, decrease the PRF or scale. And then, so typically you're going to use a higher PRF for high flow arteries or high flow veins, and a lower PRF for slow flow arteries and veins. If you have aliasing, which is when the positive Doppler shift information wraps around to the negative, there's a whole bunch of things you can do there. I'm not going to go into them due to time, but the first thing you need to do is increase the scale, because in the world of OB/GYN, that's pretty much what's going to fix it. And then the sweep speed, which was also mentioned, is how many waveforms can you fit on the screen in 1 second? And why would we want to stretch out a waveform? Well, in the world of vascular ultrasound, we want to measure acceleration time, how long it takes to get to systole. Not so much in obstetrics. The reason why I like sweep speed in OB is because if I have something like an arrhythmia, if I have a fetal arrhythmia, I'll slow down the sweep speed to show more waveforms on the screen so I can show the clinician how often that arrhythmia occurs. Spectral gain, watch the brightness of your background. If it's too high, you'll overmeasure the velocity. If it's too low, you'll undermeasure. These are all controls you have. Again, caution with auto measure, because if you have a wall filter that's too high, it will throw off your settings. If you have no wall filter, it will throw off your settings. So here's a waveform with no wall filter. See, the clutter is this bright junk along the baseline. With a small wall filter applied, we have a much cleaner waveform, and the machine for doing auto measure can pick up this reversal. So this might be an IVC or something like that, or an abnormal ductus venosus. I hope not. And so you need to eyeball when the machine auto traces and make sure that the machine did a good job. Don't just trust the machine. So let's look at umbilical artery Doppler. The umbilical artery should have lots of flow in systole, lots of flow in diastole, which will give it a low resistance waveform. And that doesn't really change through pregnancy. The number, as I mentioned, the resistance will change as the pregnancy progresses, but it's not going to change that much. An abnormal umbilical artery is one where the systole increases and diastole decreases. So that's going to cause an increased SD ratio. And as I mentioned, this is still monophasic flow. It's still technically low resistance flow, but the resistance is increasing above the point where it's normal. So this is abnormal. You can't just apply terms like monophasic or low resistance. You have to quantify it. And remember I said anything over 4 is always abnormal? There you go. So this is an abnormal umbilical artery. It hasn't quite hit the absent diastolic flow level yet, but it's still abnormal and requires follow-up. This is a markedly abnormal umbilical artery waveform. Again, only flow in systole, absent diastolic flow, which is cause for concern. So as I mentioned, that technically these are monophasic waveforms, but by no means would this be considered low resistance. And then this is the reversal of the end diastolic flow, which again is a very concerning finding. Delivery is indicated. So in one European study that they did of 245 patients, they said the perinatal mortality of absent reversed end diastolic flow is 28%. I think it was absent or reversed end diastolic flow was 28%, and up to 98% needed the ICU. So these babies may have acidosis, asphyxia, prematurity. They could have brain bleeds from the prematurity, renal anomalies. They may even have aneuploidy. Maybe that's the reason for the abnormal blood flow. And then also biophysical profiles, which is an ultrasound test that may or may not include the non-stress test component, is also an important part of fetal well-being screening, because any fetus less than a score of 4 always has acidosis. So, but as I mentioned yesterday, they said that for certain types of severe FGR, the biophysical profile score may turn abnormal the day before the fetus expires. So it'd be nice to move faster than that. The ductus venosus, which connects the umbilical portion of the portal vein in the liver to the IVC. I might have said SVC earlier, that was an error, it's IVC, is a shunt. And so we can readily see this with ultrasound, and it's telling us what the heart is doing. And we use it for fetal growth restriction and also for high drops evaluation. So it's right there. On color Doppler, make sure your PRF with color Doppler is set high enough so that nothing is aliasing. And then you're going to see this little bit of aliasing right where the umbilical vein makes the curve. So we talked about the hockey stick yesterday. Right where it makes that curve for the hockey stick, you're going to see a vessel going straight back to the IVC. And that's this little area of aliasing right here. In 3D, you can see it right here, connecting the IVC and the intra-abdominal umbilical vein. For the waveform, the key thing here is nothing touches the baseline. Again, ductus venosus, nothing touches the baseline. Forward flow in all phases of the cardiac cycle. We have peak systole, ventricular diastole, and then atrial contraction. And it's this A wave that you want to watch because we don't want it touching the baseline. So for this, you're going to want to trace the waveform, and we'll get a venous pulsatility index. And again, here's a chart. This can also be done, as I mentioned, in the first trimester. Usually the resistance is higher in the first trimester. It does get lower. The resistance is higher in the first trimester. And then, however, it still should never touch or go below the baseline. If it does, that's always abnormal. And in the first trimester, it can document impaired cardiac function, congenital heart disease, or redistribution of the blood for some other reason. The ductus venosus is easily found in sagittal. So again, here's the umbilical portion of the portal vein. Here's the ductus venosus, and here's the IVC. And again, this waveform should always be nice low resistance, lots of diastole or lots of flow with the atrial contraction. And then again, when the A wave starts getting lower and lower, that's abnormal. And again, if any reversal at all in the ductus venosus of the A wave, always abnormal. The IVC Doppler, the IVC and the hepatic veins normally have a little bit of reversal, so that's okay. It can touch the baseline. It can go a little bit below the baseline. What you should not see is a lot of flow in that A wave, or that may indicate tricuspid regurgitation, right-sided heart failure, and things like that. So with the IVC Doppler, here's the thing when I suspect, like for example, with fetal hydrops, if I suspect tricuspid regurg or something like that, if I think there's increased pressure in the right heart, I'll start at the tricuspid valve. Then I'll look at the hepatic vein. Then I'll look at the IVC. Then or the hepatic vein, either one, but I'll do both. If I see reversal, I keep going until I don't see reversal anymore, because that's going to tell me the severity of the back pressure. So for example, if I see tricuspid regurg, but the hepatic veins are normal or the IVC is normal, okay, that's not that bad. But if I see reversal in the hepatic veins, in the ductus venosus, I'm going to look at the umbilical vein. And if I still see it in the umbilical vein, I'm going to say, okay, wow, this is pretty significant. Then I'm going to see how far down the umbilical vein do I see it, because that's going to give me just an idea of the severity of it. I can't quantify it. I can't give it a percent of how bad it is. I just know it's really bad if it keeps going down that umbilical vein. The umbilical vein should just be a fairly steady flow. It should just be you should not see, and there can be mild pulsatility, by the way. There should not be major pulsatility in this umbilical vein. This would be abnormal. Look at the reversal of flow. So we should not see that in the umbilical vein. The MCA Doppler, the brain is normally high resistant. This again is just gestational age dependent. We expect low resistance flow in an adult, but not in a fetus. In a fetus, I mean, think about it. What's the brain being used for? It's not thinking about anything, right? So a high resistance waveform is okay in a fetal brain. And so typically we get high resistance flow in the MCA, low resistance flow in the umbilical artery. The only time we need to worry about peak systolic velocity is when we're looking at fetal hydrops, isoimmunization, fetal anemia, basically. So if we're looking to rule out fetal anemia, we must use peak systolic information, and that angle must be at 0 degrees. And if not, use the smallest angle possible. Less than 5 degrees is preferred, and you have to use angle correction. You can use MCA Dopplers for FGR using the RI and the PI. And again, when we do ratios, we do not need angle correction, but there's no good data on MCA and outcomes with FGR. It's just not reliable data. I mentioned low positive predictive value. With late FGR, again, we mentioned that the resistance in the MCA will decrease because of that head sparing effect. So here's the middle cerebral artery. When the fetus is laying with the head turned, it almost always comes right at you, meaning 0 degree angle. So to the extent you need to measure velocities, which really is only in cases of fetal anemia, you have to use a 0-degree angle. When all we're interested in is the RI or PI, then it doesn't matter what angle you come in. It's still 0 degrees is nice, but we're not interested in velocities. So the MCA should have a fairly high resistant waveform. Lots of flow in systole. Who cares about diastole? There's always some flow in diastole. When that diastolic component increases, it's abnormal. So here again is MCA Doppler. This one's normal and this one's abnormal. And again, this is all quantifiable. We're going to look at the RI and PI depending on the chart you use. But when you have this much flow in the brain, you have to wonder why. So when evaluating for high drops, I mentioned you need a 0-degree angle, no angle correction, in other words, in peak systolic velocity. And what happens with fetal anemia is that the decreasing fetal hemoglobin causes an increase in MCA peak systolic velocity. So because there's less oxygen, the blood opens up the arterioles and the arteries in the brain and says, come on, I need more blood. And so that increases you get a higher cardiac output because of the anemia, and that increases the velocities. A peak systolic velocity greater than 1.5 multiples of the median has a sensitivity of 100% for fetal anemia, but we're not going to spend too much time talking about that. And then here's an example of MCA Doppler with high drop. So again, notice that 0-degree angle. Here's a chart from MCA peak systolic velocity. Again, these charts are all readily available. Now, cerebroplacental ratio is not really used in the US. So for fetal growth restriction, some labs may use it. It is mentioned in the ISUA guidelines as an option, but there's no clear data on how to routinely use it because we don't really know what to do with it. And it's MCA divided by the umbilical artery pulsatility index. It's abnormal if it's less than 1 and can be associated with fetal distress in labor and acidemia. Uterine arteriodopply, again, not used in the US, sometimes done as part of research where we want to look at how much blood flow the uterine artery is getting. With hypertension, there will be an elevated SD ratio. If it's greater than 2.6, there's a higher risk for demise and fetal growth restriction. Uterine artery anomalies usually precede umbilical artery anomalies, although again, in the US anyway, we're not really looking at uterine artery Doppler unless it's part of a research protocol. And then it's interesting, I found this chart. It shows the progression of the variables before delivery. This is 35 days before delivery with FGR. Notice that some of the changes, like the umbilical artery and the ductus arteriosus pulsatility index, are already abnormal by this point. So they're early markers. Same thing with the MCA pulsatility index and the AFI. They're already abnormal a month before delivery. However, the venous vessels are the last to become abnormal. So short-term variability of the fetal heart rate and the ductus venosus pulsatility index for veins, they start becoming abnormal, the IVC, right before delivery. And then this was, again, another chart that I found that I liked from the same article, early versus late changes. So that uterine, the uterine artery notching, again, we don't look at uterine artery, but abnormal, the abnormal umbilical artery and the veins usually are normal early on. So abnormal arteries early on, and then late is that absent and reverse diastolic flow, and then the abnormal veins. So I thought that was interesting as well. Here's a picture of me and my buddy from my trip to Dubai several years ago. Camels, they don't smell so good, but that's all right. I probably didn't by that point either. Okay, that's all for this talk. I'm happy to answer any questions. I see it looks like there's one right now. How much SD is normal for the MCA? So you're going to have a lot more systolic than you do diastolic. Again, it's all done by a chart. So as you can see, that will increase as the pregnancy progresses. So these are the peak systolic velocities. So at around 20 weeks, it's going to be 20 to 30 centimeters per second, roughly. By the time you get to near term, it's going to be between, I'd say 50 and 80 centimeters per second. Again, that's, you did ask about peak systolic velocity or SD. No, SD you did ask. SD, I don't know. I think we always use RI and PI. Did I put that chart in here? Yes, so here's the resistive index for the MCA. So we use that, or I've worked with physicians that prefer the pulsatility index, and there'd be a separate chart for that. I don't have a chart for SD. There may be one out there, to be honest. I'm not sure. There's charts for everything, so I'm sure there's an SD chart, and you're welcome to find that and use it as well. Again, these are all readily available online. One thing with Doppler that I'll mention, since again, I am the physics guru, is I'll just caution you on power levels. We know for a fact we're heating tissue when we do ultrasound. We're not heating it to a dangerous level. We have no evidence in 60 years of testing we're causing harm. But having said, as I mentioned that yesterday, ALARA, as low as reasonably achievable. So minimize the amount of Doppler you do in the brain. Again, if the fetus is abnormal, all bets are off. But if you're scanning a normal fetus and maybe you're just practicing or you're just doing a routine measurement, try to keep the power levels low as much as you can and keep the scanning of the brain, especially with Doppler, to short intervals, just because even though the risk is only theoretical, it's more prudent to do that. Thank you all very much.
Excuse me. Hello.
Yes.
Yeah, I want to ask you, what is the cutoff value for PI?
What is the formula for PI?
What is the cutoff value for PI? Pulsatility index.
Cutoff. For which vessel?
For umbilical artery.
For umbilical artery, I thought it was, I don't want to guess. I used to know these numbers by heart, but I haven't practiced recently. So let me get back to, let's do it this way. Okay, let me find my chart. Air ductus. If I don't have it here, I'll pull it up. Here we go. Okay. Umbilical artery pulsatility index. So again, as with everything, it goes 550th, 95th percentile, and it's gestational age dependent. But yeah, so, if you look here, you're not going to see too much above 1.5-ish, so I'm not saying that's a cutoff, but certainly if you see anything over that, it should raise an eyebrow, because you're definitely going to be above the 95th percentile at 1.5, except at 20 weeks. And we don't often do MCA Dopplers at 20 weeks. So for PI, these are your cutoffs. Right around here is 1.2, 1.3, around there.
Okay, thank you.
You're welcome.
Okay, there are a couple of more questions, Dr. Tracy.
Yes, where to measure the MCA? Well, the beauty of fetal ultrasound versus adult ultrasound is that we can see the head much easier in the fetus. Having said that, we always measure it in the M1 portion of the MCA. And that is at I'll call it the root or origin of the MCA. So we would always typically measure it right around here. We can't see the M2 and M3 portions anyway. So this right here is the M1 portion. I don't get it right at the origin. We get it right around here. And again, remember, it's important to see this angle. So we're going to get it somewhere right in this M1 portion. And I think, yeah, here's another image. You can see right where the caliper is. It's right near, closer to the origin. Here it's maybe a little further distal, but it's all still in that M1 portion. And uterine artery PI, high resistance preeclampsia. Well, so that's the thing. The uterine artery is likely going to be elevated in cases of hypertension preeclampsia, which is why the placenta is no good, which is why the fetus has trouble. But I can't comment too much on the uterine artery because it's not something that we do routinely here. If the resistance is high in the uterine artery unilaterally, what's the mean PI? I don't have an answer to that. If there's any other obstetricians in the room more familiar with uterine artery, please do feel to comment. The uterine artery, I imagine, could be asymmetric normally, but I couldn't comment on whether it's unilaterally, higher, lower. What do you do with that? In which plane? Always, if you're talking about the MCA, Dr. Lai, it's always the transverse or axial plane. Always, always, always. So these are just like the BPD. This is basically a BPD view, just a little inferior to the BPD. In this case, you want to get the cerebral peduncles. If you were with me yesterday, I said for a BPD, avoid the cerebral peduncles. Now you want the cerebral peduncles because that's where the circle of Willis is. So you're in a transverse plane, same plane as a BPD, and put the color Doppler on, use a small color box, right? See how small this color box is? That's what you want to do. You don't want a big color box. And put your spectral cursor right in there. Role of Doppler in predicting preeclampsia in the first trimester. I don't have information on that, especially since preeclampsia is usually a late second, third trimester clinical presentation. I can't comment on that. I'd be happy to look for an article. One thing I wanted to share. Let me get to my chat box. I'd be happy to try and get information on that if you wanted me to. Let me stop sharing because I need the chat box for a second. I have an article that, yeah. This is, hold on one sec. This is that, oh, this is for the next talk. Okay, never mind. I'll give it to you at the next talk. It's an article, a consensus statement article for the next talk that I want to make sure you all have. Yeah, I'm sorry I don't have any information on predicting preeclampsia. Okay, I think that's it for questions.
Okay, can I have a 15 minutes break, Dr. Tracy?
Absolutely, it's right in the schedule.
Yeah, sorry. So doctors, there's 15 minutes break. After come back the break, then Dr. Tracy will start her lecture.
Okay, thank you.
Welcome back, Dr. Tracy.
Welcome back. And I was hoping to share that an article, and I found another article on uterine artery with preeclampsia. Unfortunately, when the Zoom is in a webinar format, it does not permit me to share files. But if the person who asked the question, if you want to email me, you can email me at Tracy, TRACI, .fox, FOX, at jefferson.edu. And I'm happy to send you the article on preeclampsia and the uterine artery. There's a couple that I found that might be of interest.
Better you can send it to my email address, so I will share it to everybody.
That's fine, and then I'll share the other, the others as well. So I will be happy to do that.
Yeah,
I want everybody to have the information, even if I don't have it. Okay. A talk that has far less to do with physics, unfortunately, but has everything to do with ultrasound of the genitourinary tract. So we're going to talk about the kidneys, the bladder, and to a small extent, the genitalia of the fetus. Very brief on the embryology, and nothing that is a surprise to anyone, that the kidneys start out in the pelvis and from the 6th to the 9th week move up to their normal location. Similarly, the fetal gonads start out high and work their way down. Seems like a lot of unnecessary travel for me, but that's why we get the anomalies that we get in the GU system on the fetus. And then, of course, the tissue of the bladder, the ureters, etc., also is all developed. At around 4 to 6 weeks, the urorectal septum separates the cloaca, and we'll talk about some abnormalities that occur in that region as well. So whenever there's these structural abnormalities, many of them occur before, during embryology, during that before 8 weeks stage. The amniotic fluid is created around 8 to 11 weeks, and it's able to traverse the fetal skin. So the fetal skin is permeable before 22 weeks. Once the fetal skin gets keratinized, then that ceases to become a pathway for amniotic fluid creation. And so in the most of the pregnancy, certainly the second half, the fetal kidneys are responsible for amniotic fluid volume production. And the amniotic fluid is absolutely critical for lung maturity. Without amniotic fluid, you don't have lungs. So any condition, congenital or otherwise, that causes there to be an absence of amniotic fluid, there will be pulmonary hypoplasia, which is fatal. The kidneys can be seen as early as 11 weeks transvaginally, and we talked about first trimester anatomy yesterday. And you can see the kidneys, especially with today's equipment, and we talked about using the linear transducer or transvaginal ultrasound, which tends to be a higher frequency, and the urinary bladder can be seen as early as 9 weeks. Now, again, these numbers may shift as technology gets better. We can see things with ultrasound. Oh, here you go. I found a way to put physics in. So there is new equipment coming out that uses what Dr. Fred Kremkow, noted physicist, calls the new paradigm in ultrasound imaging. And it's the plane wave technology with virtual beamforming. And I'll give you just one example, but other manufacturers have it as well. But Canon has the Apleo i800, I think it's called. And I scanned with this machine, and I swear you could see DNA with it. I'm exaggerating slightly, but the image quality was like you've never seen, because it's a whole new technology. It's not the way we think of how we normally obtain ultrasound images. And so I would encourage you when you're shopping for ultrasound machines to look and see what the newer technologies are. Some of them are quite spectacular in the level of detail we can get. So I'm sure all the other manufacturers will come out with virtual beamforming and ultra thin transducers, ultra fast frame rates, etc. So keep an eye out for that. The umbilical arteries, we talked about this with the Doppler talk. So the umbilical arteries come out of the iliacs and they wrap around the bladder. So there should be one on each side. Here's the umbilical abdominal cord insertion site here, the ACI. The urinary bladder is inferior to the ACI. So if you get to the ACI and you don't see the bladder, no surprise. This image is oblique. I know it's oblique because the ACI is superior to the fetal bladder. So to get this image, you have to be a little oblique. But here you see a fetal bladder. These are the fetal legs. After 18 weeks, LMP, then you can start to see the renal parenchyma better on the fetus. There's corticomedullary definition. So it doesn't just look like a gray blob, especially if you use a high frequency transducer. Here we see a little fluid in the collecting system. We're going to talk about that. Now, the adrenal glands in the fetus are much larger proportionally than they are in the adult. And so it's very important not to confuse the adrenal gland, which is superior to the kidney, right? The adrenal glands are like little hats that sit on top of the kidneys. And remember that when you're doing your abdominal circumference, and here's the stomach, you will see the adrenal gland in that plane, and that's fine. If you go one cut inferior to that, in other words, if you're at the abdominal circumference plane, and you move your probe just a little bit inferior, you're going to see the kidneys. And the kidneys, because the bowel tends to be a little more brighter, obviously not too bright, but a little brighter, and the kidneys a little more hypoechoic, and with today's high resolution equipment, you should see some nicely defined kidneys. When doing an anatomy scan, so not just a follow-up growth, but an anatomy scan, always do the kidneys in sagittal and transverse. You don't have to measure them in sag, but you should look at them in sagittal just to make sure that everything looks structurally okay. If you're having trouble finding the kidneys, it is okay to do the renal arteries in color Doppler. Again, watch your settings, power levels, and whatever. But so here we have the aorta, and especially if you can get the renal arteries at 0 degrees, because that's the best angle for Doppler imaging, you'll be able to see them very easily. And not only can you use this to confirm that there's 2 kidneys, but if you think one or more is missing, you can use color Doppler to confirm the absence of one or more kidneys. So what happens when a kidney is missing? Well, if it's one kidney, which is unilateral renal agenesis, there's 2 things I'll mention. The first one is, first, make sure it's not somewhere else, because the kidney can be somewhere else. But if it's actually a unilateral kidney, you may go your whole life without knowing that you only have one kidney. It's non-lethal. The other kidney has compensatory hypertrophy. It gets bigger to compensate for the missing kidney. It's not uncommon and occurs in about 1 in 1,000 cases. However, as with all renal anomalies, it may be associated with other things. This should be trisomy 21. I don't know what trisomy 2 is, but it's probably really bad. Trisomy 21, Turner syndrome, other Müllerian duct anomalies, congenital heart disease, obstructive kidney disease, and VACTERL, which is a whole spectrum of anomalies. It's an association of vertebral, anal, cardiac, etc. So whenever we have a kidney problem, because our renal is very commonly associated with other syndromes or associations, whenever there's a kidney problem, I instantly say probably isolated, but let's rule out anything else. And I always think of the heart. So in this case, you want to look at the limbs as well, but I always think of the heart. So as I mentioned, if you suspect there's only one kidney, you're going to check the fetal pelvis. The kidney that's there will get bigger. That's fine. Obviously you have to document this finding. Also, the adrenal gland on the side of the missing kidney, the ipsilateral side, may get larger just simply because it has more room to grow. We expect the urinary bladder to be normal and the fluid volume to be normal. You can get along just fine with one kidney. So here's some examples. So in this case, it's the left kidney. Here's the stomach. Here's a kidney with some urinary tract dilatation, and here's nothing. Again, always go to the pelvis because it may be there. Here's the right kidney. Notice how well we can see it in sagittal, by the way. And here's the left renal fossa, which is empty. And again, getting the renal arteries at 0 degrees is preferable. Here we can easily see the right kidney, and there is nothing on the left. If the renal agenesis is bilateral, this is uniformly lethal. Again, no kidneys means no fluid means no lungs. So because there is anhydramnios, there is 0 urine production. Death will occur from pulmonary hypoplasia. Now, this may be isolated, as I mentioned, or again, part of a syndrome or association. Also, it may be associated with abnormal genitalia or cardiac anomalies if you suspect it's part of something like, again, VACTERL or something like that. Potter's sequence is something that we don't necessarily see with ultrasound. It's after delivery. They have flat faces, low set flat ears, and the limbs may be deformed. And this just has to do with being in an environment of no fluid. Amniotic fluid is not just essential for lung growth, it's essential for development as well. So for the limbs to develop normally, etc. So this is a finding after delivery. They'll say there's Potter facies, for example. Again, there will be the absence of fluid, which is anhydramnios, or some may say severe oligohydramnios, bilateral empty renal fossa, and again, absent renal arteries. So there's 2 big things we think of when we put the probe down. Well, 3 things we think of when we put the probe down and there's no fluid. Either autosomal recessive polykidney disease, which we'll talk about soon, bilateral renal agenesis, or premature preterm rupture of membranes. So, there's only so many things where you won't have any fluid whatsoever, but this is one of them. So, and you want to look for fluid because if it's premature rupture of membranes, there may be a little bit of fluid, and maybe this pregnancy is viable if they can, put the patient on bed rest and hopefully it closes up and the fluid can rebuild. Then maybe there's a possibility of survival. But if it's no kidneys, there is no chance for survival. This is uniformly lethal. So again, we have a situation where there's no fluid and all we see are the adrenal glands. There's bilateral renal agenesis. Fortunately, this is not as common. And then looking for the renal artery, we're seeing probably a piece of the IVC here, but there are no renal arteries going directly to or from the transducer. So I mentioned the Potter sequence, which again is seen with severe obstructive uropathy. So for example, posterior urethral valves, which also causes no fluid, bilateral renal agenesis, and again, I mentioned autosomal recessive polykidney disease. So there's no fluid, which again causes those flattened facial features and fetal limb deformities. So when you don't see a kidney in the renal fossa, you have to look and see if it's ectopic. The most common place and the first place to look is the pelvis. So here's an empty renal fossa, here's the adrenal gland, and here it is. A little hard to see. It blends in so much easier in the pelvis. There it is right in the pelvis. And don't be afraid to use color Doppler to try and suss it out either. Less likely would be somewhere else in the abdomen, although again, there are some renal anomalies we'll talk about that are a possibility. And even less likely, but possible, thoracic, an intrathoracic kidney. I've never seen it, but it can occur. So one of the anomalies where you may see a kidney missing and you're not sure what's going on is a congenital anomaly called cross-fuse ectopia. So not only is the kidney ectopic, but it's mushed into the other kidney. It's blended into the other kidney. And so you have fused kidneys on the same side of the body, more common in females than males, and rarely detected in utero. Although you can do color Doppler and you may see a couple renal arteries on the one side. The horseshoe kidney, again, less likely to be diagnosed in utero. After birth, after delivery, it's the most common kidney anomaly, but we don't see it. So it's still common, but we don't see it in utero. But what you're going to see are kidneys that are malrotated. The inferior poles of the kidneys are tilted in toward each other, and there's an isthmus, a bridge that connects the two kidneys. This has no bearing on anything. You can go your whole life with this and not know you have it. It doesn't usually tend to cause any obstructive uropathies or anything like that. It's just a common congenital anomaly. Male to female, 2 to 1. And a duplicated collecting system, which is about 5 to 7% of antenatal urinary tract dilatation. It can be diagnosed in ultrasound. I mean, here's a great example of it. So this is duplication. There are 2 ureters coming out of this kidney. In this particular case, there's 2 kidneys, but on the one side, it's a duplicated kidney. And so very commonly, it's the upper pole moiety that is the one that gets obstructed. In this case, there's obstructed of the upper and lower pole moieties, but usually it's the upper pole. And then commonly there's a ureterocele with these in the urinary bladder as well. And in this case, there's reflux into that lower pole moiety. So here is a great example from the Kalin book showing the upper pole more likely to be obstructed related to a ureterocele, and there's more likely to be an ectopic insertion into the bladder, as you can see here. And then here's a kidney showing dilatation. Urinary tract dilatation. So somebody had asked about this earlier. So we need to measure the anterior, posterior, or AP diameter of the renal pelvis. We're going to look for any dilatation of the renal calyces. We're going to look for parenchymal thinning in the cases of severe dilatation. One of the things is the kidneys are not very tolerant to having their tissue compressed. And so when the tissue gets compressed from collecting system dilatation, it can cause damage to the parenchyma and loss in tissue and function. Dilatation, again, most commonly in a duplication is in the upper pole. Male fetuses almost always have mild dilatation. In fact, there's a standing joke with sonographers that if you see a little bit of dilatation in the renal pelvis, it's almost always a male. But it doesn't mean it's pathologic. It's below the level of where it's abnormal. The different types of obstruction, the UPJ is ureteropelvic obstruction. That means the renal pelvis, not the fetal pelvis, but the renal pelvis. So the UPJ obstruction is right at the kidney level. And then a UVJ obstruction is ureterovesical, meaning it's at the insertion of the bladder or from the bladder itself. And in the case of a UVJ obstruction, you may have a dilated ureter that you can see. With a UPJ obstruction, the obstruction is just at the level of the renal pelvis and there is no dilated ureter. And then vesicoureteral reflux, VUR, is another common type of urinary tract dilatation. A consensus group got together and said, there's too many terms and they're confusing and they're meaningless. Cheliectasis, hydronephrosis, pyelectasis, right? We used to call it pyelectasis. There is only one term now, and it's called urinary tract dilatation, or UTD. And again, the goal is to get rid of the confusing terminology. So here is how you measure, always in transverse. You can, you still should image in sagittal, don't get me wrong, but for the measurements, they're always done in transverse. Get it right at the hilum of the kidney here, right in that mid-pole of the kidney. They're showing the spine here. This image is 180 degrees opposite this one. That's why it looks a little different. The spine's here and here's the kidney. And you're just going to measure the inner to inner margin of that renal pelvis. And we usually measure bilateral, but certainly if one appears abnormal, you should measure it. So what is abnormal? This chart is from the article I wanted to share with you, but I will share through email. And so what you're going to do is you're going to look at the AP dimension measured on transverse, the maximal diameter of the intrarenal pelvis. You're going to say yes or no whether there's calyceal dilatation. So once you question urinary tract dilatation, you're going to follow these steps. If there is calyceal dilatation, does it involve the minor calyces, yes or no? How's the parenchyma look, normal or abnormal? This is subjective. How does the parenchyma look just in general? Is it echogenic? Are there cysts? Is it thinned? And the ureters, can you see them or not? If you can't see them, they're probably fine. If you can see them, they're probably abnormal. And then how does the bladder look? Is the wall thick? Is the bladder really markedly dilated? That kind of thing. Then also here's the quantification. So at 16 to 28 weeks, the renal pelvis should be less than 4 millimeters in AP diameter, AP dimension. Greater than 20 weeks, it's less than 7 millimeters, and postnatal should be less than 10. So the magic number is 4 for that anatomy scan that you're doing. Once it's above 4 or above millimeters, then we're going to do follow-ups. And it may be nothing. This may resolve, this may stay the same, and it may not go anywhere. But if it gets to the 3rd trimester, and it's still growing and it gets larger than 7 millimeters, then it's time to call in the pediatric urologist, get a consult while the patient is still pregnant, because there's going to be things they're going to need to do after delivery. And one of them is a renal ultrasound, but there's going to need to be at a follow-up at, like some kind of pediatric center. And the good news is we can look at vesicoureteral reflux in the infant now with ultrasound contrast. So we don't have to x-ray everybody anymore. And then the other thing you need to ask is, if you have less than 4 millimeters, which is normal, what else do you have? So again, looking for calyceal dilatation. Is it central? Is it peripheral? What's the thickness? All this stuff. This should all be normal at all stages of pregnancy. And anything in here that you can't say is normal, or you say yes, then a workup is probably needed. So here's the article I'm going to send you. It's the Multidisciplinary Consensus on the Classification of Prenatal and Postnatal UTD. It's the UTD classification system. It's from 2014. Some notable names in here. And Beverly Coleman, Dr. Coleman is the chief radiologist at CHOP, the Children's Hospital of Philadelphia, which is, I'm proud to say, is one of the most prestigious in my hometown. So in the article, they have the UTD classification system from normal to A1 to A23. And then underneath A1 and A23 are P1, P2, P3. And it's nice because they show images. So like if you see this picture, here's the classification. And again, I'll direct you to the article to be able to see this in more detail. I know it's tough seeing it on a computer screen. And then they have a classification system based on this consensus, based on this classification system. They have this presentation and how do you deal with it? What's the management? So if it's 16 to 27 weeks and less than 7, or greater than 28 and 7 to 10, then you're going to follow the thing. And if there is at least one thing in here, okay, so there's central calyceal dilatation or you wouldn't be doing this. And then is there anything in here? But then you also have to look, is there anything in here? Because you're always going to use the most concerning finding. So let's say that there is a 6 millimeter dilatation at 20 weeks, but the ureters are abnormal. Then you're going to go to here, increased risk. But if everything falls in here, you know, the bladder's normal, the ureters are normal. If all this is normal and the only finding is central calyceal dilatation, it's low risk. So again, anything that falls in here, so 16 to 27 weeks greater than or equal to 7 millimeters or greater than 10, equal to or greater than 10 at 28 weeks or higher, these are all going to fall under the high risk category. So you always use, if you have just one thing over on this side, you have to call it high risk or increased risk. And then again, here's some just images, how we measure. So again, we're going to measure this AP diameter. I always like to look at these at sag and transverse, because in transverse, you can measure that AP diameter of the renal pelvis, but in sagittal is how you're going to qualify the calyces. So whether it's central or peripheral calyceal dilatation. And for example, here you can see these calyces really dilated out in the periphery, and then this is duplication here. The posterior urethral valves are the most common cause of urinary tract obstruction, and it's exclusive to males. And this is obstruction that allows no fluid to come out. This is complete obstruction of the urinary tract. The type 1 is the most common. The keyhole sign, and what do we mean by keyhole? The old-fashioned keys. Here's the keyhole sign, and that is a hallmark for posterior urethral valves. So the so-called type 1 type, I'm not going to get into the different types, is most common. This is treatable. So they can do fetal surgery, which is simply doing something similar to an amniocentesis and putting a shunt in that connects the bladder to the outside of the fetus, and that will drain the fluid out of the bladder, because the problem is this is backing up into the kidneys and causing the kidneys to have parenchymal destruction. So it's such severe obstruction. So there's severe oligohydramnios and pulmonary hypoplasia if nothing is getting out of the bladder. And the other thing that can happen is you can have the urinary tract rupture. So the kidney can rupture, and then this is really bad for these organs. Vesicoureteral reflux is in 10 to 20% of antenatal urinary tract disease, urinary tract dilatation is 10 to 20% is from reflux. Is the reflux from transient obstruction? Maybe at one point there was increased pressure from a transient obstruction and that caused the reflux, or maybe part of the urinary tract delayed its maturation, and so that failed and there's reflux. They're not really sure. There's different causes. There may be a familial predisposition to this, and 40% of affected infants will have renal scarring. So, you know, it's kind of important to be able to take care of this reflux, which is why you meet with the pediatric nephrologist before the fetus is born. Megacystis is dilated bladder due to an obstructed bladder outlet or bladder outlet obstruction. It's usually found in males. This is not necessarily as severe as posterior urethral valves. Although here you can see, look at the small chest here. This is probably pulmonary hypoplasia. Pulmonary hypoplasia and a markedly dilated bladder and no amniotic fluid. So this would be bad. This has anhydramnios. And then this is a first trimester case of megacystis. But again, right now there's still fluid. Well, that's also because fluid comes from other sources in the first trimester. But at least if you see it in the first trimester, it could be dealt with potentially, again, with a shunt or something like that. And posterior urethral valves, again, that so-called keyhole finding. So you may need to relieve that pressure and get the fluid out with fetal surgery. If nothing is done, it may cause what's called prune belly syndrome, which is really just a hallmark describing what the baby looks like after birth. So they had this massively distended abdomen, and then that pressure is relieved, and so they have a so-called prune belly finding after birth. That's, of course, the ones who survive, for whom it's not fatal. And then the ureterocele. So again, when you have a duplication, there may be a ureterocele, which looks like a little bubble or cyst within the urinary bladder. And the problem is that causes obstruction, which is why you have that upper pulmonary being dilated, which is what you're seeing here. And that is because of this ureterocele. If the obstruction occurs early enough of the kidneys, regardless of the cause, if it occurs early enough, you're going to have parenchymal destruction. And that parenchyma, the way that you know the parenchyma is being destroyed, is it starts getting replaced by cysts. There is a variable appearance to this, but the patient will usually start to get macrocysts and the parenchyma will disappear. And eventually you'll see a real thin kidney and it will have no function. So here you can start to see little cysts. So it's very important when you're doing these kidney ultrasounds that you look at the kidney. You're not just documenting presence of kidney, but you want to look for these little cystic areas. And sometimes they're of no concern whatsoever. And we'll talk about multicystic dysplastic kidney. Some people just get kidney cysts. However, you know, and of course it's not common in the fetus to have cysts, just like an adult does. But it's very important to look at the parenchyma because you want to call this early if you can, because we have first of all, we have to make sure if it's bilateral or unilateral. And also because this can cause complete replacement of the functional renal parenchyma, we have to make sure that the fetus has enough amniotic fluid so that the other kidney is functioning. So multicystic dysplastic kidney is a non-hereditary renal disorder with macrocysts. So you can see them. They can be quite large, actually. And again, it overtakes the kidney and there's no functional renal cortex. This is usually unilateral, which is a good thing. If it's isolated, it can be completely asymptomatic until adulthood. If it's bilateral, well, it's the same as not having kidneys. There's complete destruction of the renal parenchyma bilaterally, severe oligohydramnios with pulmonary hypoplasia. So here are examples again of multicystic dysplastic kidney. So now again, this can be something that isn't even found in utero. You might not see any cysts in utero. And then as an adult, they start getting this multicystic dysplastic kidney changes. And again, it could be unilateral. If it's bilateral, they may need a renal transplant. It's just if we see it in the fetus, it depends how much of the kidney is overtaken by these cysts, because if enough parenchyma is destroyed, then that kidney is not going to be functional. So for example, now, you might imagine that this looks like calyces. How do you know it's not calyceal dilatation? You have to be able to connect it to the renal pelvis. If it doesn't connect to the renal pelvis, it's a cyst. So it's very important to look at it in two planes, at least two planes, right? Maybe coronal, sagittal, and transverse. And to really look at it and make sure whether or not these are whether they're connected to the collecting system. If they're isolated to the parenchyma, do not confuse it with urinary tract dilatation. And here's a case of bilateral multicystic dysplastic kidney. There's no fluid. This is not survivable. So in the cystic kidney disease department, we also have what's called polycystic kidney disease. It is hereditary, either dominant or recessive, but there are non-hereditary types as well. And we talked about multicystic, obstructive, and simple cysts already. Now let's look at the hereditary ones. The autosomal dominant polycystic kidney disease, which needs a better acronym, is non-lethal and is usually unilateral. This is the one they used to call adult polycystic. And it's small cysts along the periphery of the kidney. So again, when you see this like string of pearls sign, if you will, and it's unilateral, we do have to wonder if this is autosomal dominant polycystic kidney disease. And they can get cysts in other organs as well. And these patients will get followed for life. They may need a kidney at some point if it's bilateral. Autosomal recessive polycystic kidney disease is uniformly lethal. And with this type, it's almost always bilateral. There's no fluid. This is where, again, that Potter sequence comes in. And these are microscopic cysts. You can't see the cysts. And because the cysts are so small and they cause enhancement of the sound waves, you will have bilateral, uniformly hypoechoic, enlarged kidneys. So you're going to see these big old white kidneys in there, echogenic kidneys, or I should say hyperechoic kidneys, which is from these multiple microcysts that you cannot see. And again, there will not be, generally speaking, not fluid with this, certainly not further along in pregnancy. And they will have pulmonary hypoplasia. Here's more cystic kidney disease. Again, I already showed this. Okay, so here's a chart. This is actually coming from a book I have coming out, hopefully this year. Who knows? It's been going on for 5 years at this point, so I have no idea when I'm ever going to see it. But here's a chart of potentially lethal renal anomalies. Now, this chart was designed for adults because it's a book on the adult abdomen. But having said that, this all applies to the fetus. So these are some of the findings: multicystic dysplastic kidney, again, fatal if bilateral; autosomal recessive polycystic kidney disease, always lethal; renal agenesis, always lethal; and posterior urethral valves is lethal if it's not surgically corrected in utero, which is possible now with a shunt. Notice I don't have autosomal dominant polycystic kidney disease. That's because it's not usually lethal. There's only one kidney affected. And then with the fetal genitalia, so before 12 weeks, and with today's ultrasound, yes, we can see things earlier and earlier. And yes, I've looked at gender before 12 weeks. The difference is I don't tell the patient. So I won't tell a patient until 16 weeks, generally speaking, depending on how well I can see what the gender is, because we're just not that good. Now, somebody wrote an article many years ago and they called it the angle of the dangle, meaning the angle of the genital tubercle. So if it points down, it's a female. If it points up, it's a male. With non-invasive prenatal testing with cell-free DNA, we can get the gender at 10 weeks with a blood test. So it's not really, we don't need to really put ourselves and twist ourselves into all these qualifications telling the patient, well, it might be this. If they really need to know the gender, get a blood test. Because why do we look at the gender? It's not just to tell mom and dad whether it's a boy or a girl. We look at the gender because there are certain anomalies and genetic things that only occur in males or only occur in females. Or if the fetus is a female, we have to look because it means this. So it's important from an anatomic and holistic standpoint to know what the gender is, because it may apply if, for example, you're looking for certain types of anemias and things like that. Also, gender is helpful in identifying zygosity in twin pregnancies. If you see discordant genders, there's no way they're monozygotic. The accuracy is between 92 and about 100%, as long as you don't guess. I don't guess. If I can't tell, I tell them I can't tell. The female genitalia is usually the three little lines right between the legs, and the male genitalia, usually you can see a scrotum with or without testicles and the penis coming out like this. And some people describe that as the turtle sign, like a little turtle sticking his head out of the shell. And here's another example of male genitalia. And the female genitalia, some people describe it as looking like hamburger buns. So I've probably just turned people off from hamburgers, but that's another descriptor that we use. And it's helpful to point out to the patient when they say, you know, I don't know. I mean, a lot of people look at the male genitalia, they know what they're looking at when you point it out to them, but not so much with the female. The testicles descend after 25 weeks. They may or may not, they usually do. And then both have descended after 32 weeks in most people, most fetuses. Failure to descend is a cryptorchidism, and that other testicle, that missing testicle, we're not going to find it in utero. It's hard enough to find it after they're born, is usually in the inguinal canal, but the fetus or the baby can have an ultrasound after birth. Ambiguous genitalia, so bifid scrotum or undescended genitalia, the micropenis and abnormal curvature of the penis, hypospadias and epispadias. Hypospadia is when the urethra is mid-shaft of the base of the penis. Epispadias is when it's on the other surface. Another problem with genitalia we can get is if you have a male fetus with female appearing genitalia, it may be congenital adrenal hyperplasia. So if the patient is suspected to have congenital adrenal hyperplasia, there are steroids that can be given that will stop this virilization process of the gender conversion. So we need to stop that conversion of the genitalia. So here's some examples of genitalia. The 3D can be helpful to try and figure out what's going on. Sometimes you'll need to do an amniocentesis. And again, it could be something like hypospadias or something like that, which makes the genitalia appear abnormal. Sometimes you can't really tell till after birth what it's going to look like. And I had a case like this actually, and we wanted to publish it, but we never did. But we had a case like this where we just couldn't tell, and it ended up being a totally normal female, but it was just so prominent in utero that it really threw us. And then the last thing here is cloacal exstrophy or bladder exstrophy. The bladder everts, so that basically the tissue on the this is a ventral wall defect. The tissue of the ventral wall kind of turns inside out. And so this is actually the inside of the bladder here. So what you're seeing is the inside of the bladder flipped inside out and sticking through the ventral wall. When there is cloacal exstrophy, there's a lot of anal defects as well. And again, this could be part of a syndrome involving anal defects and the kidneys and other things. So here you can see everted hemibladders. So there's two bladders and they're both everted. That's a pretty interesting form of this. Here there is bowel sticking out. The terminal ileum is coming out and it appears to be like a penis. So, you know, very confusing. I've had patients with this before. It's very confusing, but here's the hallmark for any type of cloacal or bladder exstrophy. You will not see a urinary bladder. So this is why when you're doing that second trimester scan, it's so important to document the bladder. And if you get through the whole scan and you still haven't seen it, you have to bring the patient back because you have to make sure there's a urinary bladder, or it could be this condition. And again, if there's this condition, there may be other associations with it. Renal mass is fortunately not very common. Some syndromes predispose patients like Beckwith-Wiedemann and tuberous sclerosis. Congenital mesoblastic nephroma is the most common renal tumor in the fetus. I've gone my whole career without seeing one, which is fortunate, although I have seen other tumors, neuroblastoma, for example. Wilms tumor is actually rare in the fetus. That's usually seen after they're born. But the congenital mesoblastic nephroma is a hyperechoic solid mass that replaces the kidney and may cause polyhydramnios. Here's another example, kidney, and the other kidneys replaced by this tumor. 50% of congenital abdominal masses are renal. So again, you may see a Wilms tumor. If you do, it's solid or partially cystic. If it's bilateral, it may be something called nephroblastoma,tosis, which is bilateral renal nodules. Again, these are we're in rare territory here. This is the stuff you probably won't see, although Beckwith-Wiedemann's a little more common and may cause renal tumors, as I mentioned. And then lastly is the neuroblastoma, which although it can occur in utero, it's a mass of the adrenal gland, not the kidney. But this is usually a complex cystic mass, usually found in the third trimester. So differential diagnosis of adrenal masses. Here are some examples. Ovarian cysts. This is the very last topic. Not uncommon. I've seen these a handful of times. So you see a cystic structure next to the urinary bladder, put on color Doppler. There's no color flow. It doesn't look like it's coming from an ectopic kidney. And it's a female fetus. It's probably an ovarian cyst. These always go away. They are incidental and they have no adverse consequence. We mention it and then we'll see it again on a growth scan, but they always go away. And that's it. Thank you for allowing me to give you this talk. And I see we have a couple questions. How early in gestational stage does autosomal recessive kidney manifest on ultrasound? These occur early, so I can't give you the exact date, the earliest that you can see it. I imagine with today's first trimester ultrasound, certainly with autosomal recessive kidney, because this is, it's genetic, right? So it occurs from the time of development of the embryo. So I've never seen it in the first trimester because I think we just don't get a ton of patients in the first trimester routinely. We get a lot of them in the second trimester, and that's when I've always seen it. But I would imagine that you could see it. The multicystic kidney, not as much. I would think that'd be more of a second trimester finding. Again, if there's any obstetricians in the room that have seen it in the first trimester, feel free to chime in. And then what is first trimester oligohydramnios? Well, that isn't quantifiable because there's no AFI outside of the second and third trimester, but it's subjective. So in the first trimester, we look at the sac size. And if you have a fetus that looks like it's wrapped by the sac, shrink wrapped, then it probably is oligohydramnios. You know, a little easier to say something in the at 13 weeks when they're a little further along and almost second trimester. But in the first trimester, you really have to look at the sac size. And even though we do not use the gestational sac for dating the pregnancy, the sac size can be helpful to tell you if it's normal or not. So if you have an 8-week embryo and a 6-week sac, you have a definite problem, and that requires short order follow-up. I see a hand raised.
Now, what is the outcome of first trimester oligohydramnios, doctor?
Usually poor. I mean, it depends on the cause, but they're usually not viable pregnancies.
Okay, thank you.
You're welcome. Okay, thank you, Dr. Tracy. Thank you very much.
I thank you.
Dr. Lakshmi Ravi. Are you there, Doctor? Yes. Hi, good evening, Dr. Lakshmi.
Can I start your scene?
Yes, you can start. You can share your screen.
Yes. Can you see my slides?
Yes, we can see.
Okay. Greetings to you all, and thank you for this opportunity. I'm now going to take you towards ultrasound in early pregnancy, the normal and the abnormal findings. So what would be the learning objectives in this PowerPoint? Ideally, we would like to recognize the typical ultrasound appearances of the normal pregnancy between 4 to 10 weeks of gestation. We will understand the role of measurements in early pregnancy, and I'll show you the typical ultrasound appearances of ectopic pregnancies. So, conception and implantation. So we understand that by the 4th week, the blastocyst becomes fully embedded into the endometrial tissue, and this 3 to 5 week interval period, this is where we see this fluid-filled chorion cavity is identified as a gestation sac at around 4.5 to 5 weeks of gestation. So what we ideally first see in ultrasound is nothing but the fluid within the chorionic cavity. So the ultrasound features of early pregnancy would be somewhere between 0 to 4.3 weeks, you have no ultrasound findings. By 4 weeks, 3 days, you can see a small gestation sac like this. Probably the gestation sac diameter would be around 2 to 3 millimeters. From the 5th week onwards, you can see this the gestation sac and the yolk sac appears by 5.5 weeks. And then I would be explaining to you what is the intradecidual sac sign, the double decidual sac sign, and also about the double bleb sign. From the 6th week onwards, you will be able to see the embryo, and then later you can appreciate cardiac activity. So the earliest sign of an intrauterine pregnancy is a small fluid-filled sac seen like this. So what is the intradecidual sac sign? So you see this is the endometrial cavity line, and you see that the sac is a small, rounded, well-defined fluid collection embedded in the echogenic decidual tissue, and it is eccentrically located adjacent to the hyperechoic line representing the endometrial cavity. So this is the endometrial cavity line, and here you see the sac. So translating this on ultrasound, do you see this endometrial cavity line here, and you see the sac sitting here? So this eccentrically located sac pushing this endometrial cavity line, this is called as the intradecidual sac sign. And the next thing is the double decidual sac sign. So this, if you see, this is the gestation sac, and you see a nice echogenic rim surrounding the sac, and that is produced by the opposing layers of the decidua capsularis covering the sac and the decidua parietalis lining the endometrial cavity. So this is called as the double decidual sac sign, where you see the echogenic rim of surrounding the G sac. The next thing is the double bleb sign. This is nothing but a sonographic feature where there is visualization of a gestation sac containing a yolk sac and an amniotic sac, giving an appearance of two small bubbles. So you see here, the embryonic disc is actually located between the two bubbles. So this is the yolk sac and this is the amniotic sac, and you see the embryo in between. But this is a very transient finding because, as you all know, the amnion will rapidly enlarge, and somewhere around 5.5 weeks, you can see this double bleb sign. So you see the representation here. This will be the amniotic sac and this will be the yolk sac, and the embryo sitting between the two sacs. So this is called as a double bleb sign. And the intradecidual sign can be used to differentiate between a true and a pseudo gestation sac. So what is the difference between the true gestation sac and a pseudo gestation sac? So in the true gestation sac, you ideally have the two hyperechoic rings consisting of an outer and an inner ring, which is the double decidual sac sign. Whereas in a pseudo sac, this is a finding in an ectopic pregnancy, and this is due to a thick decidual reaction surrounding the intrauterine fluid, and it generally has a single layer border. The true gestation sac is always eccentrically located, whereas a pseudo sac is located centrally inside the uterine cavity. This is generally of a round shape and has vascularity, peripheral vascular flow, whereas here the shape tends to be irregular and it is avascular. So look at this. So this is a true gestation sac. This is the intradecidual sac sign, and this is the double decidual sac sign. But this is a pseudo gestation sac. You see that there is an irregular gestation sac here, and this is actually a pseudo gestation sac of an ectopic pregnancy. Now, how do we do the measurements? So you do it in the three orthogonal planes and take the mean sac diameter, and this is what is useful. You measure the gestation sac as long as you do not see the embryo to date the pregnancy. Once you see the embryo, then you can measure the crown rump length to date the pregnancy. Now the yolk sac. The yolk sac, this structure is the yolk sac, and that is the first anatomic structure identified within the gestation sac. What you see actually on ultrasound is the secondary yolk sac, which forms at 28 days. The primary yolk sac is an embryological structure, and that is actually not seen on ultrasound. The presence of the yolk sac definitively confirms the presence of an intrauterine pregnancy. So normal and abnormal appearance of the yolk sac. Generally, the yolk sac has a maximum diameter of about 5 to 6 millimeters at approximately 10 weeks of gestation age. So obviously, this is the yolk sac, and you see the nice embryo sitting here. But whereas in this, you see a large yolk sac measuring around 10 millimeters, and you don't see the embryo here. The next thing is, how does this appear in multiple pregnancies? So this is a dichorionic diamniotic twin, and this is a monochorionic diamniotic twin. So you see that, you see here, you have two chorionic cavities here. So it is dichorionic. You have only one chorionic cavity here, so monochorionic, and you have two yolk sacs here. So probably this will be a diamniotic. So we all would understand that the early pregnancy scan or the first trimester evaluation is the best time to determine chorionicity and amnionicity in multiple gestation. You can see two sacs like this, and you can see that there are two developing embryos inside, and this you can say is a dichorionic diamniotic gestation. Now coming to how to identify between a fused placenta and a monochorionic placentation. So in a dichorionic diamniotic placenta, you have what is called as a twin peak sign. So what actually happens is the groove between the membranes at the insertion. The placenta actually goes in between, because in a dichorionic diamniotic twins, what actually happens, here you have the amnion, then you have the chorion, then once again chorion and the amnion. So this will be, the placenta actually appears thick, and it goes in between the sign, between the membranes, and this is called as the twin peak sign. So if you see something like this, then that is a dichorionic, diamniotic presentation. Now I'll tell you what is the T sign. The T sign is the monochorionic diamniotic presentation. So what happens in a monochorionic placenta? The placenta is actually single. So you do not have the intervening placenta in between. And hence, the site of insertion will be clear like this. So it cleanly joined the chorionic plate as a wispy membrane, and that is called the T sign, and that signifies a monochorionic diamniotic presentation. So now if you see only one cavity and you do not see the intervening amniotic membrane, even at 10 or 11 weeks of gestation, then you think that it is a monochorionic monoamniotic twins. And these, because now you have a nice, better quality ultrasound equipments and you use a transvaginal scan, you can identify these conjoined twins as early as 10 weeks of gestation, because you will see that the twins are in direct opposition with each other and they have inseparable skin contours which will be persistent at the same anatomic level, and this can be identified in early gestation. Now coming to the gestation sac anatomy. As I told you, the amniotic cavity rapidly expands, and slowly what would happen, the chorionic cavity gets obliterated and there will be fusion of this amnion and chorion between 12 to 16 weeks of gestation. Now once we know the gestation sac anatomy, next we'll go to the embryo between 6 to 10 weeks. So at 6 weeks, obviously you see the crown rump length, and that will be around 5 to 8 millimeters. By 7 weeks, the limb buds appear, and by 8 to 9 weeks of gestation, you can clearly differentiate the cranial end from the caudal end, and you will be able to see the rhombencephalic cavity. By 9 to 10 weeks of gestation, you will see the physiological herniation of the midgut that becomes identified. And you also see that by 10 weeks of gestation, you can see the arms, elbows, and legs nicely by 10 weeks of gestation. So look at this. So this is 7 weeks. You see the fetus, the embryo here, and you see the small limb buds. But by 8 weeks of gestation, you see you can identify the rhombencephalic cavity. You know what is the cranial end and what is the caudal end, and you can see the small limb buds appearing here by 8 weeks of gestation. 9 weeks of gestation, yes, you can further be able to appreciate the limb buds nicely growing well, and by 9 to 10 weeks, small structure which is physiological herniation of bowel. Now this is very, very important, because you should not consider this as an omphalocele, because this is a normal finding. You will have bowel herniating into the base of the umbilical cord by 9 to 10 weeks of gestation. So a word on physiological herniation of the midgut. Ideally, fetal liver occupies majority of the abdominal cavity at 6 weeks. As there is rapid growth of intestines, and because it exceeds the growth of the abdominal cavity, physiological herniation of intestines occurs into the base of the umbilical cord. But we need to understand that ideally it goes inside by 10 to 11 weeks, and by approximately 12 weeks, the midgut returns into the abdominal cavity. Normally, the bowel herniation is about 7 millimeters, and it is only the bowel which comes out at this point of time. Hence, even at 10 weeks, if you have a large omphalocele containing liver or heart, then that is considered pathological. Now, once we understand about this physiological herniation of bowel, and that it should not be misinterpreted as an abnormality, you can also, as I told you, you can also see the nice limbs and the digits appearing well by 10 weeks of gestation. See, this is just how you can see all the 3 segments of the lower limb and the upper limb by 10 weeks of gestation. So this is about the embryo between 6 and 10 weeks. Now, how do we measure this? So the guidelines say that you need to take a mid-sagittal section of the whole fetus. Ideally, the fetus should be horizontal. You magnify it till it fills most of the screen. The fetus should be in neutral position, and the endpoints should be clearly defined. So that is the crown rump length. But initially, between 6 to 9 weeks, because the embryo is flexed, the head is actually flexed So the maximum dimension is actually the neck rump length by 8 to 9 weeks. Now we understand that the crown rump length would increase approximately by 1 millimeter per day, and the important thing is between 6 to 12 weeks of gestation age, determining the crown rump length measurement is the most accurate method of dating pregnancy. And a simple rule is the gestation age in days can be estimated by adding 42 to the embryonic length. So first trimester dating. If you see only the gestation sac, then that is 5 weeks. If you see gestation sac and yolk sac, that is 5.5 weeks. If you see gestation sac plus yolk sac plus embryo, then that is 6 weeks. And if you see a CRL greater than 5 millimeters with the fetal cardiac activity present, then that goes by 7 weeks. So measure the crown rump length when the embryo is more than 7 millimeters. And always CRL. Please do not change date, because this period is the most accurate dating available, and hence we should not later on change our dates once you have assigned dates by CRL. Now we'll come to the terminology in early pregnancy. What is a non-viable pregnancy? It is a failed intrauterine pregnancy. A viable intrauterine pregnancy is presence of embryo with visible cardiac activity. The intrauterine pregnancy of unknown viability is when you have a G-sac with a mean diameter of less than 25 millimeter and you can't see anything, or there is an intrauterine G-sac containing embryonic pole with a crown rump length of less than 7 millimeters with no embryonic cardiac activity. Then you're uncertain about the viability. So what are the features diagnostic of a miscarriage on a transvaginal scan? If you have a mean sac diameter of greater than 25 millimeters and you do not have an embryo with a crown rump length of greater than 7 millimeters without evidence of fetal heart activity, then you can diagnose miscarriage on a transvaginal scan. This is at the initial visit. If in cases you have some uncertainty and if it does not come to that limit, then you have to repeat the scan at intervals. So if you have a no embryo with fetal heart activity greater than 14 days after a scan that showed a gestation sac without a yolk sac, then you can come to a diagnosis of a miscarriage. And if you see no embryo with fetal heart activity greater than 11 days after a scan that showed a G-sac with the yolk sac. So this is how you can do a repeat scan at intervals and then come to a diagnosis of a miscarriage. Now this is just now the previous in the previous talk we was there were questions raised of what is first trimester oligohydramnios. So this is early pregnancy. You see that the CRL and the gestation sac, you see the sac is wrapped around the fetus and obviously there is no fluid around. So a small G-sac in relation to the embryo, and if there is lesser than 5 millimeter difference between the CRL and the mean sac diameter, then definitely these pregnancies needs to be followed up. Then you can have a large fluid filled collection like this, which is a subchorionic hematoma, and the subchorionic hematoma generally tends to have a differing appearance because as blood clots and that there will be a resolution of it, and so you can have varying echogenicities in subchorionic hematomas. And this is also a finding which you can document the position of the gestation sac and the size of the hematoma in early pregnancy. The next thing about diagnosing miscarriages, we should follow to the strict criteria, and especially when we are in doubt. The fundamental principle is first do no harm. So we should not misdiagnose a miscarriage because that is unacceptable and it would lead to inadvertent termination of a viable pregnancy. So we need to be very sure, be doubly sure, and recheck before we say that it is a miscarriage. So once we have completed about early pregnancy, and this is about molar pregnancy, this is a complete high datitiform mole where you see this snowstorm appearance. And here this is a partial mole where you can see a small growth restricted fetus and a large placenta with cystic spaces. So this is how a partial mole would look like, and this is a complete high datitiform mole. Classically, initially it was called as a snowstorm appearance. Now, after I'll take you towards the pregnancy of unknown location. So if you have a positive beta HCG and you do not see the sac in uterus, then your idea would be to search the adnexa. If the adnexa is normal and you still have rising beta HCG titers, then you have to wait and see, are we dealing with a very early intrauterine pregnancy? So you must wait to see whether there is a sac in uterus. Or you recheck and evaluate the adnexa to identify the ectopic gestation. If there is a rising beta HCG titer. If there is a declining titer, then maybe, okay, it's going to be a miscarriage. If there is a positive adnexal finding, then we diagnose an ectopic gestation. So this is how, this is a flow chart from Nadim et al. Where they correlate ultrasound with the beta HCG ratio, and then they give you a flow chart to tell you how do you decide depending on the rising titers of beta HCG, and how do you go by to diagnose an ectopic pregnancy or a viable intrauterine pregnancy. The criteria is the same as I showed. The earlier slide was a simplified version of this. Like, you need to correlate if there is a rising titer, either you need to wait for an intrauterine pregnancy or scan the adnexa meticulously to find out the ectopic. So we all know to identify an ectopic, the clinical signs and symptoms may be very mild, and you may have some early signs, and the patient may sometimes be asymptomatic, or sometimes she can have severe pain and she can have a fainting attack. So it's you have a broad range of spectrum of signs and symptoms in ectopic. But coming to the ultrasound findings in ectopic gestation, how does the endometrium look like? So first of all, the endometrium may be normal, or you can have a thick decidual cast without a gestation sac. Look, this is a thickened endometrium here. There is no gestation sac. Or you can have a pseudo gestation sac like this, or you can have a thickened endometrium with an intradecidual cyst like this. I will throw your attention to what is this intradecidual cyst, because I do not want you to mistake an intradecidual cyst for a gestation sac. So this is a decidual cyst. So a decidual cyst are thin-walled, and they are thin-walled simple cysts, and they are usually located at the junction of the endometrium and the myometrium. So you see this decidual cyst located at the endomyometrial junction. So if you remember the previous slide, if you look for the intradecidual sac sign, then you will clearly identify that this is not a G-sac, this is only a decidual cyst. And secondarily, they do not have the hypoechogenic rim. They are thin-walled cysts, whereas a gestation sac will have the double decidual sac sign. So all these things can help you to identify a true gestation sac from a decidual cyst. Now coming to beta HCG assays, the discriminatory zone is around 1,500 to 2,000 units with transvaginal scan. Doubling time of beta HCG in a normal viable intrauterine pregnancy is about 48 hours, whereas in ectopics, the serum HCG levels rise at a much slower rate, probably a lesser than 60% increase over 48 hours, and it is not steadily declining. Absent beta HCG rules out a live pregnancy, although a chronic ectopic may be present. Now, going to the ultrasound findings in an ectopic pregnancy. So what and all are the common findings? So adnexal mass that contains a yolk sac or a viable embryo, an extra-ovarian adnexal mass, the tubal ring sign, and free fluid in the cul-de-sac. So all these things may be signs of an ectopic pregnancy. But we also need to understand that sometimes 1/3 of pelvic examinations who have ectopic pregnancies may have no sonographic findings. Now, if you see an adnexal mass like this, which contains a yolk sac or an embryo, then that is a definitive criteria for an ectopic pregnancy. But most often, you do not get that criteria. What you see is, you see an extra ovarian adnexal mass like this, and that becomes the most common sonographic finding in an ectopic gestation. And you have this free fluid with the internal echoes in the cul-de-sac. And if you see the presence of free fluid in the cul-de-sac, then that is a very important sign. And you can also see this extra ovarian adnexal mass sitting here. So The tubal ring sign is the second most common sonographic finding, and that around the tubal ring sign, you may be able to see vascularity, and that is called as a ring of fire appearance. But you also need to understand that it is not always very easy to identify the tubal ring. You see here, this is the ovary here. These are bowel loops, and you see the small subtle tubal echogenic ring here, very, very small, subtle, and you see the perilesional vascularity. So sometimes picking up an ectopic needs meticulous scanning of the adnexa. And these are the various appearance of the tubal ring. Most often you may have vascularity, but there are instances where you can see the nice tubal ring, but it may not pick up that much vascularity as shown like this. So what is the definitive criteria for an ectopic pregnancy is on a transvaginal sonography, an extrauterine G-sac with a yolk sac or an embryo with or without cardiac activity is the definitive criteria for ectopic pregnancy. What is the criteria for a probable ectopic pregnancy? Then that is an inhomogeneous adnexal mass, which is referred to as the blob sign, and an extrauterine sac-like structure, which is referred to as the bagel sign. So this is the paper from in 2018 in UOG by Nadim et al., where they said that the morphological ultrasound types known as the blob and the bagel signs should now be reclassified from suggesting probable to indicating definite tubal ectopic pregnancy. That means because these two signs are the most common presentations of an ectopic pregnancy, we consider the positive predictive value is very high, and therefore, if you see these two signs, then you should consider them at being at a very high risk of having an ectopic pregnancy and should be treated as such. So this is the blob sign, which is an extra-ovarian adnexal mass, and this is the bagel sign, which is a sac-like structure. Now, I would like to throw your attention to this particular case where this was diagnosed as an ectopic gestation and posted for surgery because they did not find an intrauterine G-sac. Now look at this. Yes, there is a mass like this, but where is it located? And look at the ring of fire appearance. This is intra-ovarian because you see the ovarian tissue surrounding this, and a simple corpus luteum should not be mistaken for ectopic gestation. So 3 days later, you can see the nice intrauterine G-sac coming out here, and this is nothing but the corpus luteum. And hence, if you see intra-ovarian, please think that it could be a corpus luteum and repeat a scan. 3 or 4 days later, you may be able to pick out this small G-sac, intrauterine gestation sac. The next thing what I would like to bring your attention is, if you see a sac not centrally located, and if you have an eccentrically located sac in the lateral end of the uterus, then how do we go about it? See, look at this image. This is a sagittal section of the uterus, and you have a laterally placed sac sitting like this. And if I take the transverse section, this is the fundus of uterus, and you have a sac sitting like this. So what is the differential diagnosis of an eccentrically located G-sac? So now I'm going to take you towards what are all the possibilities. So an eccentrically located gestation sac can be an ectopic or an intrauterine pregnancy. It can be an ectopic if it is an interstitial pregnancy, or if the sac is located in the rudimentary horn of a uniconvate uterus. Maybe it is communicating or non-communicating. But the same eccentrically located sac can be intrauterine if it is in the horn of a septate or a biconvate uterus. Then you will call it as a true cornual pregnancy. Or if it's situated in the lateral angle of the endometrial cavity, then you will call it as an angular pregnancy. We will see some case scenarios like of this, then you will understand it better. So how do we diagnose an interstitial pregnancy? Eccentric location of the G-sac within the myometrium, but it will be clearly separated from the endometrial cavity. Demonstration of the intervening myometrial tissue, separating the medial margin of the gestation sac from the echogenic endometrium. And the myometrium surrounding the gestation sac will be markedly thin periphery, and there will be less than 5 mm of surrounding myometrium in all planes. So, and there is also one other sign, which is the interstitial line sign in the diagnosis of an interstitial pregnancy. So you see a thin echogenic line. It extends from the lateral corner of the endometrium through the myometrium, connecting the G-sac. But though the sign has a good sensitivity and specificity, this sign can be seen only when the pregnancy is very early in gestation. And if this is a little more advanced, sometimes you won't be able to demonstrate this sign. So look at this. Look at the relationship of the sac with the endometrial cavity. On transabdominal scanning, you know that this is an eccentrically located G-sac. But when you do a transvaginal scan, you can clearly see that the endometrium is separate from this gestation sac. And you also see that the surrounding myometrium of the sac is very, very thinned out. And three-dimensional image will give you a nice idea of the superolateral borders of the sac. So this is actually the endometrium. This is actually the interstitial pregnancy. And you see that nicely the intervening myometrium here, but you see the surrounding myometrium extremely thinned out. You have no myometrium surrounding the sac. And this is really dangerous because this can go in for a rupture at any point of time. So once we understand about interstitial pregnancies, I'll just give you some case examples. So this is a case of adenomyosis uterus. UPT is positive, but sac not visualized. You are not able to see the sac both in transabdominal and in transvaginal scanning. But if you meticulously scan the lateral edge of the uterus, you see that you see the G-sac situated in the lateral end of the uterus, and you see the vascularity, peripheral vascularity with color Doppler. And this is once again an interstitial pregnancy. So never forget to scan the lateral corners of the uterus for an interstitial pregnancy. So 3D will clearly let you know, like see, this is the uterus here, and you see the sac sitting here, and you see that there is absolutely very, very less thinned out myometrium surrounding the sac here. One more important thing, when you see an eccentrically located G-sac, not all eccentrically located G-sacs are interstitial pregnancy. So look at this G-sac now. It has a nice broad-based connection with the endometrium, and you see that the sac is now situated in the lateral end of the uterus, but inside the endometrial cavity. And this is called as an angular pregnancy. And you see the nice myometrial mantle surrounding the angular pregnancy. And this generally tends to have a favorable outcome. So now I'm going to show you an example of a heterotopic pregnancy. So one pregnancy inside, this is intrauterine pregnancy, and one is an interstitial pregnancy. So the minute, so you see nicely, one is sitting in the cornua and one intrauterine. So even if you see an intrauterine pregnancy, please scan the cornua and the adnexa to evaluate for a heterotopic pregnancy. So now I'm going to take you towards a cornual pregnancy. What is a true cornual pregnancy? So cornual pregnancy in the rudiment, this is very important because in a biconvate uterus or in a septate uterus, if you have a pregnancy, that's okay. It's not going to be very harmful or dangerous. But if you have a cornual pregnancy in the rudimentary horn, I would like to make you understand what would be the ultrasound features, because that you have to diagnose, that may be life-threatening. So a single interstitial portion of the fallopian tube in the main uterine body, a gestation sac mobile and separate from the uterus surrounded by myometrium, a vascular pedicle joining the G-sac to the uniconvate uterus, and there is no visible continuity between the endocervical canal and the lumen of the pregnant rudimentary horn. We'll see how the images would look like. See, this is the uterus now. This is a transabdominal section showing an empty uterine cavity. But you see the gestation sac situated here, separate from the uterus, and it is nicely surrounded by myometrium. But what you're seeing here is a vascular pedicle joining the G-sac to the uniconvate uterus, because this is actually a uniconvate uterus. And you see this G-sac situated here, the surrounding myometrium here. This is a vascular pedicle connecting the G-sac to the uniconvate uterus. So you see this is a banana-shaped uterus, nicely showing you the uniconvate uterus. And you see here the G-sac sitting here in the rudimentary horn, and this is the 3D rendering of the G-sac in the left rudimentary horn of a right unicornuate uterus. So this is important to understand. And we have a paper on the diagnostic dilemmas of an eccentrically located G-sac, the role of 3D ultrasound, to make you understand that it is very important that we identify these pregnancies in the rudimentary horns and these unicornuate uterus very early in gestation. Now we'll come to the last in this case series. So this is a trans-abdominal transverse image of a uterus, and this lady presented with severe abdominal pain and a fainting attack. And what you see here is a peripheral vascularity. You see a peripheral vascularity typical of an interstitial pregnancy, and the transvaginal image showing an empty uterine cavity. But we need to understand that degeneration in fibroids can sometimes cause severe pain and menorrhagia, and there is always a need for correlating beta HCG levels with ultrasound findings. Should always be kept in mind, because this is nothing but a degeneration of a cornwall fibroid which mimic like a cornwall pregnancy. So ideally, we always need to correlate with beta HCG levels before we take our ultrasound findings in mind. So now I'll come to the last in the section, which is diagnostic criteria for a scar pregnancy, because now the incidence of cesarean scar pregnancy is on the rise. And when I speak about early pregnancy, I need to tell you about this particular entity, and that we, in the history of a previous cesarean scar, if there is a low-lying G-sac, we really need to think about a scar pregnancy. So what is the diagnostic criteria? An empty uterus, an empty cervical canal, and the development of sac in the anterior part of the lower uterine segment with absence of healthy myometrium between the bladder wall and gestation sac. So that is the criteria for a cesarean scar pregnancy. So look at this. On a transabdominal scan, you see that the gestation sac is low-lying. You see that there is an empty cervical canal here, and you see that the sac is implanted in the scar area, and you see absence of healthy myometrium between the bladder and the sac, and you see this the peritrophoblastic flow showing that this is a cesarean scar pregnancy. This is another case of low-lying gestation sac with the hematoma. It is easy to think that this is a miscarriage, but the minute you throw on Doppler, you will know that this extensive peritrophoblastic flow clearly tells you that this is a low-lying gestation sac in a cesarean scar pregnancy. And you see the pregnancy located here, and this is a cervical canal, and you see the sac here with peritrophoblastic flow. So you see the 3D rendering where clearly it shows that the sac is in the cervicoisthmic region, and this is the cervix, and this is the sac here sitting here, and the peritrophoblastic flow. Now in cervical pregnancy, where do you see the sac? The sac is exactly situated in the cervical canal, and you have ballooning of the cervix like this, and you might have you will have peritrophoblastic flow in a cervical pregnancy. The next thing is, I would just like to draw your attention to a small structure which is a cervical polyp. This should not be mistaken for a cervical pregnancy. This is a cervical pregnancy. This is a cervical polyp. See, the lining of this is thin-walled, and you do not see the double decidual sac sign. Whereas see, the line, this structure has a nice echogenic lining here, and of course you could use the Doppler to identify and differentiate between these two conditions. But you should keep in mind that this should not be, see this of this structure, you have fluid here, minimal fluid here, and this is a small polyp sitting here, and this should not be mistaken for a cervical pregnancy. Now to the last thing of a prediction of an abnormally invasive pregnancy. So if you have a low-lying gestation sac, then does it tell you something? Yes, this was a paper by Moshaus et al. Where they said that if you measure the anterior trophoblastic border in a low-lying G-sac, then if that is lesser than 5 millimeters, then that may be give you a chance that there can be later on a morbidly adherent placenta. So this is the application of the Mosher's criteria. You see that this is a low-lying gestation sac here. This is a cervical canal. You see the sac. You see that the endometrial cavity is empty here. You see the sac sitting nicely here. And if you try and measure the anterior myometrial thickness, it's only around 2 millimeters. So this tells you that this is little risky and needs to be followed up. So always, when you do an early pregnancy scan, the G-sac is generally situated within the upper half of the uterus. If it is situated in the lower uterine junction in the cervico-ischemic region, then you can do the simple algorithm. We also have a paper on this approach to a low-lying G-sac. The usage of the simple algorithm will help you to click the diagnosis very easily. The minute you see a very low-lying G-sac, first use the color Doppler. If there is absence of peritrophoblastic flow and the sliding sign is positive, because if there is a miscarriage, there will be absence of peritrophoblastic flow, and on little gentle pressure, the sac will move up and down, then that is a cervical stage of miscarriage. So the absence of peritrophoblastic flow will lead you to a diagnosis of a cervical stage of miscarriage. Whereas if there is a presence of peritrophoblastic flow, then you must look at the location of the sac. If the G-sac is inside this canal, cervical canal, then that is a cervical pregnancy. If there is a history of a previous C-section and the sac is seen at the scar site and you have deficient anterior myometrium thickness, then you must think of a cesarean scar pregnancy. If the sac is low-lying, but you have nice sufficient anterior myometrial thickness like this, then you simply have to watch this pregnancy for a probability of a placental invasive pregnancy. So a simple algorithm, but it will be very useful if you put it into your clinical practice. So I would like to conclude this session by saying that when we do an early pregnancy, what do we rely on when we want to say whether it is a miscarriage or not? Just one case scenario. This is a primee conceived after 6 years of infertility, 8 weeks by last menstrual period. She's presenting with history of bleeding PV, and the scan done outside is suspicious of early pregnancy failure. So look, what is that you're seeing? You see an irregular sac-like structure measuring about 3.2 into 3.3 cm. So obviously greater than the 25 millimeter criteria, but this is the first time you are evaluating the case. So when we saw something like this with her, considering that it is a very precious pregnancy, we simply said, okay, I will see you a week later, because I would just like to reevaluate you rather than saying that this is a miscarriage. Just look what happens a week later. What you see here is just fluid in the endometrial cavity, and you see a nice small G-sac appearing 1 week later, and you see the nice embryo developing. So I would just like to tell you that it's always a combination of clinical judgment, HCG, ultrasound findings, and repeat ultrasound. Please, repeat ultrasound or hormonal studies should be used in the diagnosis and management of early pregnancy failure. And it is better we do not jump into conclusions at the first visit itself. So what are the common pitfalls with ultrasound in early pregnancy? Exercise extreme caution with regard to last menstrual period on history taking. Visualize all of the uterus. Never neglect to scan the adnexa. Avoid labeling subchorionic bleeds as additional twin gestational sacs. And you must know or beware of the ultrasound findings of pseudo sacs. To summarize, early diagnosis of ectopic pregnancy is important and today facilitated by the use of sonography and serum HCG. Knowledge of the variety of appearance of ectopic pregnancy will aid in the diagnosis. We need to have a high degree of suspicion, and you must know how they present on ultrasound. 3D ultrasound definitively aids in the precise location of the sac in cornual ectopics and to assess for uterine anomalies. And last of all, missing an ectopic and misinterpreting a normal intrauterine pregnancy as an ectopic, both can be avoided by meticulous scanning. Thank you so much for your patient listening. Do I have questions to answer?
Yes, doctor, there are 3 questions in QA box. If you can open it.
Now, how do maybe I should stop sharing? Yes. Yes, the twin peak sign is also referred to as the lambda sign. Yes. Can you elaborate about subchorionic hemorrhage? Okay. Regarding subchorionic hemorrhage, this is really a cause of concern because the minute you see a subchorionic hemorrhage or you document a subchorionic hemorrhage, everyone becomes anxious. But maybe 80 to 85% of the GSACs with subchorionic hemorrhage generally tends to have a normal outcome. Sometimes the woman is asymptomatic, she does not have bleeding, but you see a GSAC and you may have some fluid collection next to it. Sometimes she presents with spotting and you may have a subchorionic hemorrhage. Only thing which I have seen in my practice is the size of the subchorionic hemorrhage. When you do a repeat scan and the size keeps on increasing greater than 7 centimeters, or if it does not subside, then the probability of that going in for a failure is high. But generally, as you do a repeat scan, most of them resolve, and I think that should not be a great concern. Next, what are the ultrasound findings to diagnose early tubal pregnancy before the appearance of a gestation sac? So ideally, on ultrasound, because this is ultrasound in early pregnancy, on ultrasound you have to identify the GSAC. So once you have a beta HCG above the discriminatory zone, and if your uterus does not show a GSAC, then ideally you have to scan meticulously the adnexa. And you have to scan the extra ovarian, the area around the adnexa. But most often, sometimes you may not be very lucky the first time, because the tubal ring may be very, very small, but a repeat examination may help you after 3 or 4 days to identify that. The next thing is, do you say, as seen in the last case, there is a possibility? Yes, I just want to tell you that there is a possibility of a viable pregnancy. Because what we saw in the last case was not the empty gestation sac. It was only fluid in the endometrial cavity. The sac later on appeared after a week. So generally, this is just to show one case scenario where the first time you see, you jump into conclusion, maybe we may be disrupting a normal intrauterine pregnancy. A repeat ultrasound done 3 or 4 days or a week later may give you some additional findings. So basically it is in my nature to wait and not make a diagnosis at the first visit itself, unless I see a CRL greater than 7 millimeters with no cardiac activity. That is great, that is miscarriage. But all the other things are like in doubt, and you can do a repeat examination. Have I answered all the questions? No. Please, can you shed light on the diagnosis of management in a blighted ovum? Okay, this is what just now I was speaking on it. So to say it is a failed fetal growth, that is where you need to be cautious. The other things, I think, once you're sure that it's a failed fetal growth, then you can take your own decisions of how you're going to terminate that. Even after main sac diameter of more than 2.5 mm. That is what I'm saying. There is no single criteria which you should rely 100% on. Believe on your clinical judgment, believe on the beta HCG values, and then take a decision. Is it okay? Have I answered all the questions?
Yes, all the question has done. Thank you very much, doctor.
Okay, thank you so much.
Thank you very much. We are just ending the session here, doctors. See you tomorrow. We will share the recording of the session by tomorrow morning, so you can review it. Some of the delegates asking presentation slides, if you can share, Dr. Lakshmi.
Okay, I'll make a PDF, maybe not the whole
PDF
presentation.
PDF.
Yeah, I'll make a PDF and I'll do it.
Because
probably
some of the slides is going very fast. So
okay, fine.
Yes.
Okay, thank you, Yasin. Thank you. Bye.
Thank you. Bye-bye.